think we'll have a start. So, Lucas, can we start the live stream, please? Yeah, good morning. Welcome everybody to the meeting of the Health Scrutiny Committee, which is being broadcast live across the whole of Nottinghamshire. Before we begin, I'd like to acknowledge team rotation in Democratic Services support to the committee. Noel Meneman has moved to support other committees, so I want to record our gratitude to Noel for all his hard work and advice and support to this committee over the years. Catherine is now supporting the committee, and our new health scrutiny lead with James advising on governance side. So welcome to you both. Thank you very much. Minutes of the last meeting held on the 16th of July 2024. Can I accept the minutes as a true and accurate record, please?
Can I just make one alteration and firstly say thank you to Noel, because as Vice Chair he was really helpful to me. But bullet point 2, I don't remember there being a Steve Anderson taking part in the meeting, so I feel it might have been a couple of things mixed together, but bullet point 2.
I'm sure we can get that corrected. So can I accept the minutes as a true accurate record? Thank you. Apologies for absence. Councillor Jackson is hoping to join us later, and I know Councillor John Oley is running late, newer commitments, I understand. Anyone else?
Councillor Martin's in the building. He'll be up in a few seconds.
Thank you.
James?
Apologies have been received from Councillor Steve Carr for other reasons, but a substitution will not be sent. Councillor Michelle Welch sent her apologies for other reason, and Councillor Henshaw will be stepping in as a substitute. Thank you, Chair.
Right. Declarations of interest. I thought you were going to put your hand up, Bethan. Yes, Bethan.
Thank you. Since taking over as Chair of Health and Wellbeing Board, it means that I'm Vice Chair of Health, Nottinghamshire ICP, appointed Governor to Nottinghamshire Healthcare Trust, Shared Forest Hospital Trust, but I've taken legal advice and they said I can take part in the meeting.
Thank you.
Chair, and my daughter's training to be a nurse.
Thank you. John?
Chair, as a GP, it directly affects my illness at every single level. So that's
I'm sure you won't impair your judgment. Thank you. We'll move on to the first substantive item agenda, which is number 4, which is the Nottinghamshire Healthcare NHS Foundation Trust Integration Improvement Plan update. And I would like to welcome Jan and Diane to the meeting. And would you like to present your report? Thank you.
May I start, please, by saying that we're really sorry that Ifti Majid, the Chief Executive, can't be here today because he's very unwell. But if he was here, I know that he would acknowledge the Section 48 and the publication of that report, and he would want to apologise publicly to all of the families and all of those impacted by the atrocities of June the 13th, in particular thoughts with the families of Grace, Barnaby and Ian, and also Wayne, Marcian and Sharon. He would also say that we accept all of the recommendations and we should and could have done much better. I'm going to hand over to Jan.
Thank you, Diane. As Diane said, unfortunately, Ifti can't be here today, but we were asked to come to the committee. We came a few months ago and you asked us to come back to let you know how we were progressing with our improvement plan. So I thought it might be worth starting just by updating members on the improvement plan, and the shape of that improvement plan. So this is an integrated improvement plan, by which we mean we have looked at all of the issues facing Notts Healthcare at the moment, and we have realised that we need one plan that tackles those issues together, and that really looks at the underlying causes of why we got to where we got to and what we need to do to improve. So next slide, please. So I just wanted to go through the shape of that improvement plan to start with. Sorry, are we able to move to the next slide? Thank you. Perfect. We looked at what are the underlying reasons, as I say, behind the issues that we found ourselves facing, and we identified 5 key drivers for improvement that we needed to make. The first and the most important and the largest section of that is around patient safety and quality improvement. And Diane, as our chief nurse, leads on that programme. And you'll see that there are a number of projects within that programme. And the bits in the coloured boxes at the top of there, I'm not expecting members to read all of this, and I believe Catherine is going to send the slides around after the presentation. But the bits in the coloured boxes at the top are the areas which we had to tackle immediately following the first Section 48 Part 1 report, which was published in March of this year. We're now adding to that in terms of Section 2, and I'll come on to that a little bit more. The bits in the white are the long-term sustainable projects that we have in place in order to make the improvements that we need to make. So firstly, as I say, patient safety and quality improvement. The second area we've called leading for the future. What we recognised was that we haven't always supported our staff enough with really clear leadership, with really clear policies and processes and operating procedures, and we needed to put those in place in order to ensure that staff are working within a very clear framework. So all of those projects are around tackling that, alongside a specific project on Rampton. I think we discussed Rampton last time we came, and members will remember that in the first part of the Section 48 report, a specific section was around Rampton, where we had received a previous inadequate CQC report, and as a result we had a focus on improvements at Rampton. The third part is the finance and productivity programme. I think your next item will highlight the challenges that the NHS in Nottingham and Nottinghamshire faces at the moment on finances, and our trust is no exception to that rule. For the first time in 23-24, we posted a deficit, and this year we have a deficit plan again to our budget. Our aim is to get to financial sustainability by the end of March 2026. And so this year it's a stepping stone towards that full financial recovery. It's very tough, and there are a lot of projects within that programme that we need to tackle in order to achieve that. The third part is people and culture. We do nothing without the people who work for us, and we need to make sure that people who work for Nottinghamshire Healthcare are well supported, that they're trained, they're invested in, that they're engaged, that they should be absolutely heart and centre of the improvement, and that they want to stay working for us, because we know that having people retained with us with the right levels of experience and knowledge will really help us to improve. And then finally, we recognised that our governance wasn't as strong as it could be throughout the organisation. And so we have a programme around governance, making sure that we've got that really clear framework in place. Also looking at things like, recently the Darcy report has been published, which highlights an underinvestment in digital, for instance. And so we have put our major digital programme in that section as well. And that's led by our Chief Medical Officer, Sue Alcock. If you go to the next slide, I think, no, first of all, I was just mistaken, there wasn't another slide on that. I just wanted to explain a little bit about the phasing of the plan. So in our plan, we recognise that there are 4 key phases. The first one was the immediate action that we took as soon as the Section 48 report was published back in March, the Part one report, which was to try and make sure that we were safe today. There were some immediate actions that we needed to take. One, for example, was around waiting lists. So we had, I think, close to 1,500 people waiting for their first appointments to be seen by our local mental health community teams. We undertook to contact all of those people, and which we did, and we made sure that all of them had a plan in place to help keep them safe while they were waiting for that first appointment. The second section was around those Section 48 recommendations and also our finance recovery plan. And so that was the work that we undertook immediately again to tackle the issues that had been highlighted in Section 48. Some of those are ongoing. Some of those we were able to achieve reasonably quickly. So an example of one that we achieved reasonably quickly was that one of the issues that had been identified was that we needed to ensure that our staff were better equipped to deal with people with learning disability and autism. And that coincided with NHS nationally having brought out some new training, some peer-led training called the Oliver McGowan training, which really is based on the experiences of people with lived experience. And we undertook to ensure that 85% of our staff had undertaken the first level of that training by the end of July this year, which we did achieve. Other areas are more ongoing. I noticed Councillor Doddy talked about his role as a GP. One of the areas in the Section 48 was around us having better communication, better engagement with GPs. That is an ongoing piece of work. It has started, but it's not something that's going to be solved overnight. So that's phase 2. Phase 3, which is kind of where we're morphing into for some parts of our programme now, is about the long-term sustainability of the actions that we're taking. And also we have a target that's been given to us by NHS England, which is that in effect at the moment we are in what I would call special measures. It is called the NHS Oversight Framework, and we're in segment 4, which is the bottom segment of that oversight framework. And with that brings mandated support from NHS England and a very great deal of regulatory oversight into our work. NHS England have set us the ambition of exiting from that segment 4 by March 2026. And so we have a set of transition criteria, which I will talk about in a little bit, by which we will be judged on that. So the aim of phase 3 is to get us to that point, to get us that long-term sustainability, and to get us out of that special measures, if you like, category. And then finally, phase 4, we're calling it back to good. When we talk about good, a lot of people will think about the CQC judgments because good is one of the CQC judgments. But actually, what we mean by good is that patients and carers and communities feel that the service that's being offered by Notts Healthcare is good, and also that our staff feel that it's good to work at Notts Healthcare, and that's the really important part of what we need to do in that phase 4. Okay, go on to the next slide, please, Catherine. Thank you. So we thought we would just, in our report, we've given you quite a lot of detail about what we've been doing since we last came to the committee and the work that is still underway. Just to highlight a few parts of that. So I've also talked about the transition criteria. I'll come to that later. Another area that we have is that we were given a 1-year extension to our licence to run Rampton High Secure Hospital. During the course of this year, it will be decided whether we should be granted a longer licence to run Rampton, and we've been doing a lot of work at Rampton in order to meet the conditions for that relicensing. And some of those, I think the detail of that is in the report. We also have had the publication, as Diane said, of part 2 of the Section 48 report, which was specifically around the care of Valdo Calacane and the opportunities that we missed in that care. We've put in place a full programmatic approach to our plan, and we are receiving a lot of support from national and regional and local colleagues and we have the transition criteria in place. And if you turn to slide 4, you will see that we have highlighted what those additional recommendations were that came from part 2. And also we do have some current actions that we are taking on that. And again, some of the detail of that is in the report. And what I think it would be better to do is, rather than go through that in detail, is to ask members, if they have any questions on that. I just wanted to say a little bit about some of the improvements that we have seen. And in the report, you will see that there is a table. We're now in a different relationship with the CQC. The CQC, rather than coming periodically at quite large intervals to do a large inspection with teams of inspectors, are now in our services most weeks. And they are coming in, they are examining specific services, and they're examining specific questions within those services. And usually they're coming with 2 or 3 inspectors at a time and giving us really quick feedback. And that's actually helping our learning as we go through. And you'll see a table in the report which updates where we are on those inspections. They are not full-blown inspections, so they are not giving us a judgment on every area or on every service, but they are giving us some judgments, and you will see that we are making improvements from the latest judgments that have been made. We've also had positive feedback on the Rampton relicensing that I just mentioned. One of the key things that we identified was that we needed to strengthen our clinical leadership, and Diane has recruited senior nurses for all of our services now to provide that strong clinical leadership alongside a strengthened medical structure. And we have something now that we call the triumvirate, which is basically having an operations lead, a medical lead, and a nursing lead in each of our care groups. And that's really beginning to bear fruit in terms of the work that's being done, the focus on quality, focus on patient safety. We're also making good progress with local mental health team waiting times. I mentioned them, I think it was around 1,500. I think we have less than 1,000 now waiting for local mental health teams. That's still too many. Demand is extremely high, but we are trying to manage that better, and we have much better oversight of those waiting lists than we did have. We've also introduced a new patient safety incident response framework, and I will leave Diane maybe to say a little bit more about that in a moment. And we've carried out much more comprehensive risk assessments for the patients that are in our community mental health teams, and we've improved the quality of those risk assessments. And we're also making good progress in reducing the number of people waiting over 18 weeks for assessments in those community mental health teams. I've already talked about the triumvirate leadership. Just a quick word about the transition criteria that have been set for us. There are 7 areas for that transition criteria. Sorry, Catherine, onto the 8th slide, please. And those transition criteria are, as I say, number 8, please, sorry, Catherine, are grouped in 7 areas: leadership and governance, specifically a transition criteria around Rampton Hospital; culture, which I think we all know that culture trumps strategy every time, and culture is really important for us to get right; quality and safety, which is at the heart of everything we do; regulatory compliance; operational performance; and financial performance, because all of this work that we are doing to improve the quality of our services is being done at a time when our financial position is extremely challenging. So we have to balance everything that we do. We know that actually if we get the quality right, the finances will look after themselves, because doing things right the first time is the most cost-effective way of doing things. But there is a period when that becomes a real challenge to try and balance those two things. And lastly, I just wanted to talk about the way in which we're governing, if you like, our improvement. I've mentioned that we have very strong regulatory oversight. The Integrated Care Board and NHS England meet with us monthly, and they check our progress on all areas of our plan, including having deep dives into particular areas where they feel they need to know more. We also internally have set up an integrated improvement portfolio board, which IFTI chairs, and that reports through to a subcommittee of our board, the Improvement Oversight Committee. We have the 5 programmes, which each of them an executive leads, but perhaps more importantly, in some ways, is that we've set up 3 other real key areas to our governance. We have a colleague reference group, and we have invited any members of staff across the trust to join that colleague reference group. Around 30 people have nominated themselves so far, including one of our staff governors, and they are there to really give us the view from how it looks working in Notts Healthcare and to really inform what we're doing. We also are in the process of setting up a patient and carer reference group. What we were very aware of was that we wanted patients to be at the heart of what we do, but having one patient and carer reference group and just parachuting people in to represent all the patients that we deal with the 2.5 million contacts with patients that we have per year was not enough. So we are setting that up so that it will be, if you like, the top of a pyramid structure. That means that we have patient and carer engagement at all levels in our plan. And then finally, we have an externally chaired evidence and assurance group. It's being chaired by an improvement director, an ex-chief nurse from a high-performing trust elsewhere in the region. And we have membership from Healthwatch, from our Council of Governors, from an integrated care board, and also from that patient carer reference group and from the colleague reference group, alongside our own deputy medical chief medical officer and our deputy chief nurse. And they are there to really examine the evidence that we put to say we've achieved the improvement that we've been asked to achieve, and to ensure that that evidence is there and that actually those achievements and these improvements are sustainable. So for us, it's a very important part of the governance. Chair, I'll leave it there, I think. There's a lot of detail in the report, but Diane and I are both here to answer any questions. Thank you.
Thank you, Diane, for the thorough presentation. One thing that in my opinion, that's always worthwhile looking at is best practice from your peers. Are you working with other trusts on, and looking at best practice that from these trusts?
It's a very good question, and it's absolutely at heart of what we're doing. And I'll give a bit of an overview, and then I'll ask Diane to say a little bit more, because Diane's brought a lot of best practice and contacts into the trust to help us. So yes, if I turn to Rampton firstly, Rampton is one of only 3 high secure hospitals in the country. And what we have done is to buddy up with both Broadmoor and Ashworth, and we have brought their expertise in to support us, and they are working really closely with us. I spoke to a colleague from Ashworth who also are on our evidence and assurance group, who said he felt that there never have been such good close working between the 3 high secure hospitals as there is now, and that's been really beneficial. In terms of the trust as a whole, we have brought in a number of people who have really good experience from other trusts, but we also have buddied specifically with Northamptonshire Healthcare Trust, who are an outstanding mental health and community trust, and we have a lot of different layers of mentoring that go into that. And we have also brought in national teams who have experience across the country to help us. But I'll let Diane say a little bit more detail.
Thank you. So thinking about Rampton Hospital and buddying with Ashworth and Broadmoor, we've got joint ward manager programs so that we can learn from each other. We've got mentoring taking place, particularly for our leadership team, but also at every level as well. And we're sharing lots of practice. So we're sharing things around, kind of core fundamentals, risk assessment, care planning, and benchmarking as well. So really well developed in our high secure service. But then across our trust, we have had support from not only the national team, but we've linked up with TZS Weir Valley, with national groups around observations, around risk assessment. We've had support from external people who've done reviews of our crisis team, our LMHT, and our early intervention in psychosis services. So lots and lots of support. But actually using our networks, particularly the Chief Nurse Network, has been really helpful. So I think you can learn as much from when things go well as what you can when things don't go well. And so we've been learning from the things that they've been doing. And we've seen some real improvements, particularly in our care planning. And CQC have noted in their last number of visits a real improvement in that area.
Thank you. Thank you. So, open up the discussion to the floor. Councillor Wilmot.
Thank you very much, Chair, and thanks very much for the report you've given. Very thorough. I've got a few observations and a few questions. The Nottinghamshire Healthcare NHS Foundation Trust Integrated Improvement Plan update is very, very interesting, and now consists of 5 significant programmes of work. Now let's look at the update on the progress taking place. The report produced additional recommendations for the Trust on, amongst other things, risk assessment and record keeping. I just wondered if you got any update on that. Obviously, the committee will be looking out in the near future for improvements in those areas, but I just wondered if there's anything that you got to report on that. I should be looking out on for the reports of the buddying arrangements that have been put in place at the high security hospitals. I shall also be looking forward to reports from the new board's especially evidence and assurance group, whose responsibility is to sign off completed recommendations, where there is clear evidence obviously of achievement and sustainability. I just wondered if there was anything to report from that group. You say good progress has been made to reduce the number of patients waiting over 18 months for assessments in community health, community mental health. Could you please give us numbers that were waiting a few months ago and possibly the numbers now waiting to show that there is some improvement. On the big conversation event, it is essential that you have more of a partnership approach so that more people become involved, so that more ideas are brought forward. You say that the crisis line performance is currently off track. Have you got any progress on that recovery plan? Progress against reducing OOA beds is off target, and have you come up with a solution or anything on that position?
John, I think that might be enough for the top. Should we let Matt answer those questions so far, please?
Yeah, well, yeah, but as I say, I've got a number of extra ones, but if we just break for just some of the report, yeah, okay.
Yeah, we can come back to you, John.
In the table on page 20, it shows Rampton Hospital still has serious issues.
John, I just said we'll come back to you.
Oh, you'll come back to me? I thought you said you wanted to come back to me.
Come back to you. We'll let them answer the question so far. Thank you, ladies.
If I may start with risk assessment. So one of the concerns, both from the Section 48 and from the CQC report, was around us looking at risk in terms of what is in front of us and not looking at longitudinal risk. We identified some issues around our risk assessment training as well, which was e-learning at the time. We have now introduced face-to-face risk assessment training. We have updated our risk assessment tool. We have learning sets around risk assessment so that we have support for people when they're considering risk and considering formulation. In terms of our performance in our inpatient services, our Safe Now dashboard, which is a dashboard that is updated every week where we know our performance on some key kind of metrics, we are consistently over 85% compliant with our risk assessment in inpatient services, and a continuing improved picture in our community services. So this is something that we've done a lot of work on and that we are now seeing real progress with.
Thank you. I'll try and knock off a few of your other questions. So I think we've already mentioned the buddying. I don't know if you want me to say any more on that, but okay. So in terms of I won't talk more about Rampton because Diane's given some good examples of that. If I turn to the work that we're doing with Northamptonshire. So IFTI is meeting with the Chief Executive of Northamptonshire on a monthly basis. As I say, they are an outstanding trust and have been for some time. And that is resulting in him coming back with ideas around how we can take things forward in our own trust. But on top of that, I think it's fair to say on a more general note that Nottinghamshire Healthcare Foundation Trust perhaps had got to a point where it was quite insular, where it felt that it kind of had the answers. And I think we are changing the culture, and we are encouraging people at all levels to reach out and learn from others. And so we are, I think, far more welcoming and open about bringing people in and supporting them. Diane's already given some examples of some of the other trusts that we've worked with. They also include trusts that have been through similar experiences. So we have had meetings with Greater Manchester, who you will may recall the Panorama programme on Edenfield. So that caused some major challenges in their trust. They are now 2 or 3 years ahead of us in their improvement journey, and we've met with them to discuss some of the key things that they've learnt from that. And we're working with colleagues who also worked with them, which is helping us to make our own improvement. And we continue it. So on Friday, I'm meeting with my counterpart at the Sheffield Trust in order to learn from their experiences. And I think we're just making it part of our daily work to work with others and to learn from others. We're also making really good use of our networks, as Diane says, Chief Nurse Network, Chief Medical Officer Network. I'm in the Strategy Directors Network. And that goes for all of our colleagues, and we're making that as deep as possible into the trust as we can. You asked about the Evidence and Assurance Group. It hasn't had it's had its first inaugural meeting, which was a set-up meeting. It won't be examining evidence until the end of this month. So the first set of evidence it will be looking at will be at the end of October. And we can report back after that in terms of what they have agreed and their scrutiny. But the conversations that we've had early on with the chair and with the members of that group would suggest that they are going to be extremely thorough. So it is no good, for instance, us saying that we've introduced something. They want to see the minutes, and then they want to see it in action, and then they want to see evidence that it's being used. So that's kind of the high bar that they're setting. I don't, I'm afraid, have the figures with me in terms of the 18-week waits between now and say March. But what we'll do is undertake to provide that for you, and we'll send that to you. In terms of the big conversations, I completely agree a partnership approach is needed. The big conversations is really primarily a vehicle for having a partnership approach with our staff. For instance, I was at our Lingsbar Hospital yesterday, talking with members of staff. They gave me full barrel. You know, they didn't they didn't hold back in terms of what they needed to tell me about how it feels to work in the trust at the moment. But they also gave me a lot of hope, because they gave me a lot of really good things that they're doing. And they were, the two key messages they were crying out for really was that they wanted some stability and some clear direction, and secondly that they wanted to be involved, and it's our absolute commitment to involve people. And what we are doing with the big conversations is the trust has 123 sites from which it operates, and it has many more of the services than that. It is extremely difficult to get around all of those, but we are committed to doing so. I think we're now up to about 40 or 50 sites that we've been to, and we are going back to each of those sites in 6 months' time. We're keeping a record of everything that people have said, and we're going back in 6 months' time to tell them what we've done about it. So we are making sure that our staff can hold us to account for what we've said and what we've done. And I think that's really important in terms of wider partnerships. So, for instance, at the big conversation yesterday, the chair of the Health and Wellbeing Board for the City Council, who's also, like Councillor Eddy, a member of our Council of Governors, attended as well and made just that point about the need for us all to work in partnership, and we're committed to doing so. In terms of the crisis line, I think hot off the press, but the good news is that we are making progress now. And last week, I believe for the first time in a long time, we were over 90% in terms of the numbers of people in the very urgent category helped within 4 hours. And there was also really good progress made on the number of people helped within 24 hours. But we know we've still got a lot more to do. And we're working hard on that. And in terms of out of area beds, in April we had over 50 people placed inappropriately in out of area beds, and that really was not something that is right, and it's not right for those patients. We have worked extremely hard to bring that down. As I say, demand is high. The latest figure that we had was that we've now got 9 people in inappropriate out of area beds, and that's been a really steady decline since April. So we continue to work on that. There's much more to do, but I think we can see the signs of progress. Don't know if Diane wants to add to that.
Yeah, I just wanted to add about crisis teams, if I may, because we're really aware of how important these teams are and that services. When people are at their most distressed or when GPs are needing to refer in, it's really important that we have a well-functioning crisis team. So, as Jan said, we have improved our compliance against the 4-hour standard and the 24-hour standard. But actually more important is the experience that people get when they're ringing the crisis team and the treatment that they get afterwards. So we're doing a big piece of work around not just assessing ourselves against the core fidelity standards, but looking at the experience of those people who are using those services. And that's a piece of work we're doing with NHSE, with the Mental Health Improvement Team, who are a group of really experienced clinicians, because the performance is one thing, but the experience is really, really important. And we're going to triangulate that with complaints and the numbers of people who then need inpatient care and the numbers of people waiting for local mental health team support, so that we do it in a really thorough and robust way and don't get just seduced by numbers.
Thank you. We'll give somebody else a chance first, John, before you. So, Giles?
Chairman, I'd like to apologise about being late. However, I was listening to it as I was coming in. I have major concerns, if I'm honest. I think I'm predominantly talking around number 3. I've read the report. It's quite bad, actually. It's serious. It's not an easy read. I think if you read the report in its entirety, it states that due to the failing, 7 people died. And my question is could this happen again? The simple fact is, you're saying you're doing lots of things, but could this happen again?
We are doing everything we possibly can to minimise the risk of this happening again. So the integrated improvement plan identifies and clarifies really all of the things that we are doing. We're doing particular work with our early intervention in psychosis team, because those are people that is the team that cared for Valdo at the time. So we've done specific work around how do we discharge people. So we no longer discharge people unless we have face-to-face discussion and contact. We've looked at people in our communities who maybe have similar presentations and the support that they're getting. We're working with the system to think about an assertive outreach function within our local mental health teams. Earlier we spoke about the work we've done around risk assessment, because that's really important as well. Seeing risk in its entirety and thinking particularly around risk to others as well as risk to self. And I think that we've said really clearly actually that we didn't do well and we could have done better, and particularly around risk assessment. So all of the work identified in the integrated improvement plan is aiming towards, with a real ambition, to minimise risk. I don't know, Jan, if you wanted to add anything.
Yeah, I guess the only thing that I can say, and I'm not clinical, but there are no cast iron guarantees that this can't happen again. But we do know that mistakes were made, and what we're doing is working to rectify those mistakes and minimise that risk.
Chairman, can I come back, please? They answered my question at the end. The truth of the matter is most people here have young children. We have young children. They're going into Nottingham. We expect them to be safe, and we expect the measures to be in place that people that need help get help. There were systematic failings, and we still can't be assured that this won't happen again. Won't happen again. How, in this day and age, can people not get the mental health assistance they need to make sure they start? And I don't want to play on this too much, but they don't go out and do the awful things that happened on that day. We now have families, sadly, that have lost children, lost husbands, lost sons because of systematic failings. It's ridiculous that we have to deal with a situation, and you can't assure us it won't happen again. If you were a politician, you'd be out of a job. Chairman, no more questions.
Shall I just comment again? So what I think, just to clarify what I said, what we can guarantee is that we have learnt from those mistakes, and we are putting right those systematic failures that you identify in the report. And we are striving very, very hard to ensure that the mental health support that people need is there and is delivered in the right way. And with all of the things that Diane has listed, those are all things that are tackling those systematic failures. So we are very confident that we can put in place those things, and we have put in place and continue to put in place those things that will minimise the risk.
May I also add that we're working much closer with the police. So in our mental health services, we have weekly meetings with the police where we're discussing people who may have recently been discharged, but equally we're looking at how we share risk and we share information. So much improved from where we were before. And it will be all of those things together that have the most impact in us, in enabling us to minimise that risk.
I mean, I just want to come back. I had finished, but I just want to come back. I'm sorry, but I spoke to the police quite recently. They've told me that people with mental health issues are being put in cells because there's not enough beds. That is still failing. We still haven't got enough beds or mental health to be able to look after people. You know for a fact that still happens, because I know it still happens, is the failings are still happening. However, you're sitting in front of us telling us you've put things in place. Why you can't assure me this can never happen again, it's unsatisfactory. I'm sorry.
John, I think, excuse me, we're fairly well, not that far down the line, I suppose, from all these tragedies. Improvements are being put in place. We've got meetings scheduled for later on this year and into next year on updates and so on. So I think we've got to give them fair chance and let them improve the services. And judge, we can judge a little bit later date. Thank you. Sinead.
Thank you, Chair. And thank you for your presentation. It's very informative. On page 21 of the report, when you talked about parents and patient and carer reference groups, I was quite interested to listen to that, as I feel no one can sort of provide the insight and feedback like the people who are experiencing that service. So I was wondering how much weight is given to these suggestions, and how are they implemented then in the improvement plan? And also, will these improvements be fed back to the people in the reference group? Thank you.
Yes, thank you. So the reference group has not yet got up and running, but what we've had so far is 3 meetings with quite a broad range of patients and carers. IFTI has been at each of those meetings, as have I, and other members of staff. And those meetings were a discussion about how we should go about setting up and making sure there's a really strong patient and carer voice throughout everything we do. But in the course of those meetings, issues were brought up about their experiences, and those have been acted on straight away and are being fed back. But what we need to make sure is that that's an ongoing process, and it's not just a process at that top level. It's a process that happens throughout all of our services all of the time. And I'm going to hand over to Diane, because as well as having a patient and carer reference group, which is very important to have in the way that we do our improvement plan, I think what's equally important, if not more important, is making sure that all of our services are delivered in partnership with our patients and carers, and Diane is doing more work on that. So
Thank you. So we have a patient experience team, and our focus now is on participation, true participation at every level. So we have people out. So if I take our mental health wards, for example, we have people who attend the community meetings to find out from those people using services, how does it feel? And what would help and what would improve your experience. So at every single level, we've got people who are talking to not only people who use our services, but to their families and to their carers. We've appointed somebody into our patient safety team who has lived experience as well, so that we have people in all of our services, because we have made an absolute commitment that we will measure quality and safety through the experience of those who use our services. And to do that, we have to be in regular conversation. So the patient reference group is fantastic, but I think that those conversations need to happen every single day, and that we need to get that feedback all of the time, and that needs to drive our improvement at every level. So if you go to our wards, for example, you see, you said we did, and you'll see community meetings, and you'll see the implementation of safe wards, which, as you will know, is kind of was led or created through the patient experience movement. So it's every single day of every single week, with this also kind of complementing and driving our improvement plan.
Thank you. John, please.
Yes, thank you, Chair. I have to say I've been to cheerier post-mortems than what I've been listening to this morning, and to think it brings back Laurel and Hardy, and every time you hear something you think, well, that's another fine mess you've gotten us into. How can an organisation actually overspend to actually provide such mediocrity is what's probably the most amazing thing that we've got here today. It's an omni-shambles, there's absolutely no doubt about that, and if you could do, you'd probably just wipe it out and you'd start over again. I'd never heard so much words about how everything's going to be corrected. I mean, who were the people that were actually creating this mess over the last number of years, and that they never heard of patients, and they never heard of staff, and they never heard of any of this? It's like you've written a whole new book that these people have never seen in their lives before. How it got to this point is probably worth an inquiry all by itself. I'm going to say that this council a few weeks ago looked at Nottinghamshire Healthcare Trust, and they looked at their flagship programme, the Family Health Partnership, and they said, who are we going to put in charge of looking after our 0 to 19-year-olds? Who's going to deliver that care? Who's going to look after those nurses? Who's going to give every child the best start in life? And you know who they decided it shouldn't be? Nottingham Healthcare Trust. They decided not to give you that contract because they had no faith in you. They didn't believe that you could look after the children of Nottingham. The same way as Councillor Jono doesn't believe that you can actually keep people safe on the streets of Nottingham by discharging schizophrenics totally out of control to go and murder people on the streets of Nottingham. I think that you've got to ask yourself the question, there's nobody here has voted to give you a contract, give you any confidence that we believe you can actually look after the children of Nottingham 0 to 19, and that's an extraordinary statement for any council to make. about one of its partnership organisations. This is the type of organisation that could bring the ICS to its knees. The flagship ICS, ICP, ICB, working through its partner organisations, through place-based partnerships, through primary care networks, right down to the GPs. We visioned something which was a circle, something very, very good. And yet at the core of it, you've got such a calamity going on that it's really hard to believe. Now, Chair, I was going to save my question to the next stage, but it's a perfect time for me to actually bring in the awarding of a contract or the taking back of a contract. So with your latitude, I'll actually bring that forward now. The Chair is aware that PICs have been noted that Nottinghamshire Healthcare Trust, these people in front of us, are going to take back an award-winning contract of 12 years duration embedded in every GP surgery in Nottinghamshire to take it back in for cost-saving measures. I can tell you this is one that provides respiratory service, atrial fibrillation, heart failure, non-cancer palliative care. It's in every surgery. It's loved by every GP. It's familiar to every patient, and it is, as I say, award-winning. And this is an organisation that we as a council would not give care of our own children to, and yet they want to take back the care of this significant contract from PICS in Nottinghamshire West into what is a failing organisation. Chair, the first things that we heard of when they started off was patient safety. They will do nothing to improve patient safety. The second is people and culture. Not a single person was consulted about it. PICs were not consulted. Your own staff were not consulted. None of the patients were consulted. None of the GPs were consulted. The primary care network was not consulted. There was not a single element of consultation throughout the whole lot of it. And therefore, what does that do? What does it tell me? It tells me that every single thing you said today is words because it's not backed up by action. Your actions are the exact opposite of what you've come here to tell us about today in terms of what you would actually like to do. So previously it was all about community engagement, not a single person engaged. And why? Because you and the ICB decided it wasn't necessary. Well, I think what we're seeing here is not what's necessary, but what's good practice, what's good for our patients, what's good for our residents, and what's good for our communities. So I don't want to hear we didn't have to do it. I want to hear we went above and beyond in order to provide the best care for these people. So when I'm reading here, we will involve the community. We will address all the challenges that we've got. Be under no illusion that the people who looked at this said they thought that the services, and this is Juliet Campbell, the MP, says, we feel that services moving into this organisation are going to be harmful. We believe that removing the embeddedness of these services and bringing them back to a failing organisation is wrong. The venues that the people use will no longer be available. We believe that the staff will not follow this measure. And we believe that this is a financially and a clinically absolute colossal error of a decision. Be under no illusion, I will call on this council to say that this decision should be postponed from the 1st of January 2025 to the 1st of January 2026, that this organisation should come back with a full consultation in 6 months' time to explain how they're going to implement this and how they're going to actually reduce error and morbidity and mortality within that group of people. And I come back again to John O'Lee's point. They can't keep people safe in the streets of Nottingham. We wouldn't trust them with our own children, and be absolutely under no illusion the primary care networks of Nottingham do not trust them taking back this contract from PICS into their failing organisation, and I hereby declare that we should stop it immediately. Sorry about that, Dan. Would you like to reply?
Thank you, Dr. John. Is this an ICB issue? A question that should go to the ICB?
The ICB and the Nottingham Healthcare Trust are part of a contract to a contract to a contract. So one's a subcontract given to another contract by another person, but they're all equally liable for the attempt to remove an award-winning contract back into a failing organisation in the same way as they can't keep the streets of Nottingham safe, and we wouldn't let them look after our children. So yes, they can take turns and they can beat themselves up about it. I'm happy to give them 50% award if they blame each. If that satisfies you, Nigel.
Thank you, John.
Shall I just say a quick word in that we were here today to talk about our improvement plan, and so what we don't have is the detail to be able to talk about the PICS contract in detail. We'd be very happy to come back and give a report.
Thank you, Chair. That will incur a necessary delay in the transfer of that contract with immediate action, that it will take them 6 months to do a patient consultation, and we've seen their activities to date that coming back to answer it in 3 or 4 months' time, the contract will already be gone. So that is not an acceptable answer.
So we've got ICB members in the chamber. Is there a comment from the ICB members?
Yeah, as Dr. Councillor Doddy did say, this is a subcontracting arrangement. So this was a contract that went out a number of years ago. It was awarded by Nottinghamshire Healthcare Trust, who subcontracted the contract to PICS. It's been working very well. Very recently, Nottinghamshire Healthcare Trust has decided to bring that back in-house, which is what they are legally entitled to do. The contract still remains the same. We've had assurance from Nottinghamshire Healthcare Trust that the services, the deliverables to the patient population will remain the same, and therefore from our legal responsibility, all we can do is ensure that the quality and assurance maintains. It is, as Dr. Doddy says, Dr. Councillor Doddy says, it is a subcontracting agreement.
Councillor Turner,
So,
if I might.
Well, yeah, I was just going to say that I think this is something that's certainly high on your agenda, and understandably so.
And a question addressed directly to yourself at the last full council.
So, I think we should move this agenda forward. I think we need to meet at a future time.
The contract transfers on the 1st of January, and the staff will be tupied, and therefore the latitude is minimal, which is why the urgency of it here today.
So let's have a chat about this outside the meeting, and let's get something sorted.
Okay, can we call on Nottingham Healthcare Trust to postpone any further actions with regards to this contract until an urgent meeting has been convened between all the parties and stakeholders? Diane?
So Diane and I are not in that position to give that commitment to you. But what we can commit to is that we will urgently take this back, and we will discuss with those colleagues involved. And maybe if we can liaise with Catherine about what we need to do next, but we cannot give that commitment. I also just wanted to make one slight clarification. The Healthy Families contract is still in existence, and Nottinghamshire Healthcare Trust still delivers that. We absolutely understand that. It has been decided not to award that to Nottinghamshire Healthcare Trust, but to go out instead to tender for that, and we understand that. But for the sake of our staff who are working really hard and do a fantastic job in delivering that contract at the moment, I think it was only fair to say that Nottinghamshire Healthcare Trust is still delivering that and still delivering it to a high standard.
Chair, the minimum we would require would be consultation with the residents, with the GPs, with the primary care network before this progresses any further. That's a minimum that anybody would respect. And it's full of every single thing they've said today. It echoes it, that their words are there, but their actions deny their words.
Well, let's have this conversation outside of this meeting, after the meeting, if you wish, John. And let's try and make progress. Thank you.
A pleasure.
Councillor McGrath.
Thanks, Chair. Yeah, just a few questions. I'm not following Dr. Doddy's speech up anyway, but Diane and Jan, thank you for coming, and I'll support you on that. God forbid this will happen again, right? And I hope it. We know it. I'm not being it that way. This will happen again, right? God forbid, no matter what you do. What does concern me as well, right, is that, as John mentioned earlier, that you still want to make cuts. So how can we actually improve on the mental health if you're already governed by a budget? What is his plan to recruit? How long does it take us, right, to train these people that are under tremendous stress, right, for what they're doing? What is our connection with prisons, right? Because there's young people going into prisons that's been released back out into the community. There's no follow-up whatsoever, right? So how are we going to control this? There don't seem to be a plan around that. Because as the gentleman that did all the horrors in Nottingham was released twice, put into an actual student flat, wasn't he? The police didn't follow it up. He was put into a student flat, right? There was no connection, no follow-up. Nobody chased up who were doing his drugs. So we're saying we want to improve, but there's no actual plan in front of us. So how are we going to improve? Because I have personal experiences about something here anyway, right? And on the other things you've mentioned about beds and backup, that hasn't happened, right? I won't reveal it, but that hasn't happened, right? And going back to 12 years ago, and John knows what I'm probably going to say now, the same happened to my family, right? 12 years ago. The MP at the time, Anna Soubry, helped the family. I'm sure you all had loads of inquiries, but nothing has changed. If you're governed by money, and listen to statement, if you're by whatever government, us now, the Conservatives before, or whatever government, you're still governed by money. If there's no plan, we can all sit there together and say, we should have done this, we should have done that. But 12 years ago, we're down the line now, and nothing's been done. So I support you on saying that something will happen, and the pressure you must be under to formulate a plan. But we need help from MPs and all that. We need help from a government, no matter who it is. Thank you, Chair.
Thank you. I think first of all, it might be worth me asking Diane to talk about some of the issues you raised there around the specifics of where opportunities were missed in the care of Aldo Calacane and the things that we are doing around the things that you mentioned, black drugs and discharge, to ensure that that doesn't happen again. But before I bring Diane in, just a little word about the financial situation. Of course, we are under financial pressure. Absolutely, we are. And I think your next item you'll hear, the system is under financial pressure. And as part of that, of course, that we have had to examine every part of the organisation and see whether we can shed some of the costs, but that doesn't apply to the clinical practice that we need. So one of the things that we have been doing, first of all, when we've had a control over the number of vacancies that we advertise, but that has not applied to clinical vacancies. We've prioritised making sure that we are filling those clinical vacancies. And as Diana said, we've actually put more money into training because we recognise if we don't get training right, we get so much else wrong. We have to invest in our staff. And actually, one of the other things we've done is to look at what's called establishment. So the number of people that you need to run services safely. We're halfway through that process at the moment. We've done it for our inpatient wards. What that has said is actually overall we need more nursing staff, and our board has agreed to put that investment in. It's also, there's some changes in that it varies ward by ward. What we found was some inconsistency, so it will help us to get a much more standard approach to that. The next phase is to look at our community teams, both in community mental health and also in community services. And we'll be carrying out that next phase. But I just wanted to assure you that we are not making cuts at the expense of patient safety. Patient safety is absolutely critical. And actually yesterday, I was lucky enough, every set of new recruits, and we have about 2 or 3 induction sessions per month of new recruits that have joined us, and we always make sure that there's an executive there to welcome those new recruits. And I was lucky enough to be that person yesterday. I can assure you I was staring at a room of about 40 or 50 people joining Nottinghamshire Healthcare Trust, and that happens 2 or 3 times a month, every month, and wonderfully enthusiastic people coming to join us. what we need to make sure is that their experience in joining us and the work that they get to help them to develop their careers within the trust, the training that we invest in them is there, and that's something we're really committed to. And finally, before I hand over to Diane, prisons. Just a quick word about prisons. We all know that there has been that early release scheme, as well as our community mental health services for Nottinghamshire. We run regional services for secure care, for secure mental health care, for both medium and low secure mental health. And we also run services for healthcare in 8 prisons across the region, including 3 in Nottingham and Nottinghamshire. And so we absolutely have that relationship with the Ministry of Justice, those liaison points with the prison service through all of that work. And our staff have been gearing up to make sure that if there are any people that have that early release that need help, that we are able to be there to give them that help. But I'll hand over to Diane now.
Thank you. So I'm really sorry that we haven't been able to articulate the actions, and that if it's been perceived as just words, that we need to go away and we need to make sure that we send you a really detailed action plan, because I wouldn't want to leave here without saying there has been so many actions taken and there is real oversight, and every day, every single day, we are thinking about this. So we will go away and make sure that we send you something that gives you more confidence. And I'm sorry if it's appeared like words. That was never our intention. So thinking about recruitment, if we take Rampton Hospital, we're now over-recruited for nurses, and what a good place that is to be. Because nurses, AHPs, everybody, we can't offer the service that we want to offer if we don't have the staff to do it. So we're over-recruited in Rampton. We have not, despite the financial challenges, stopped recruiting into clinical posts, and we will not stop recruiting into those face-to-face clinical posts, those patient-facing posts. We have a huge number of nurses, I think it's over 90, starting from the universities, local universities, who will be under our preceptorship programme. I'm a visiting professor at Nottingham University, and we have really strong links with them, as we do with Trent, and we will continue to do that because that is our future. Because as you know, we have the NHS has numbers of people who will be retiring, so we have to invest in new nurses and AHPs, and we will continue to do that. And we've done really well with recruitment. However, what we need to do is focus on the retention. We've got to keep people, we've got to nurture them, we've got to develop them. So I didn't want to leave here without you knowing that we have not stopped recruiting clinical staff. There is also something really important, and it is in the Integrated Improvement Plan, about our clinical model, because we've got to really understand and be able to articulate what our offer is, so that we have right people providing those interventions. And the right interventions will then help us to be more effective, provide a better quality service, but be more financially viable as well. There's different ways of doing things, and that is what we've got to explore. Thinking about your questions specifically around Valdo, I wouldn't want to breach any confidentiality. However, I am aware that there's so much is in the public arena, the publication of reports. So what we do know is that Valdo suffered from a paranoid schizophrenic illness, and that at times he really, really struggled to engage with us. However, what we have been really open about is that we weren't assertive enough with our engagement with him. It is not the responsibility of the patient to engage with us. It is our responsibility to think creatively and robustly around engaging with them, particularly when somebody is struggling with schizophrenic illness, with positive and negative symptoms of that illness, which we know makes it very difficult for people to engage or to come out of their environments. So we have really focused on that group of people. So our early intervention in psychosis team, as I've said, they have a really clear action plan. We have increased our staffing in that team. We do not discharge people without any face-to-face contact. We are looking at increased numbers of community treatment orders. We have oversight of our sectioning and Mental Health Act sectioning arrangements as part of the Section 48 plan. We are thinking about how do we have that assertive outreach function within our LMHTs? And would that mean people with much smaller caseloads, a different clinical model so that we can engage much more robustly and thoroughly? We have regular audits of our medication, so we know that if people have missed their depot medication. We have had bite size and webinars around the use of depot medication as opposed to the use of oral medication when people aren't compliant. I would like to have the opportunity to put this in a plan and give it to you so you can see those actions and the thought behind it, particularly from a clinical perspective, because that is something, and I go back to your question around the why, and it's a question I've asked myself because I'm still relatively new in post, around the why. Why did this happen? And I think what we would say is that we weren't always a clinically led organisation. We were a operations led organisation. And that is why the parts of this improvement plan which promote clinical leadership partnered by operation colleagues are really, really important, because you have to understand the clinical conundrums and the clinical challenges to be able to provide the right interventions and the right part of the plan. But I really would like the opportunity to put that plan in detail. Thank you.
Well, thank you for that, Diane. But what I'm actually trying to say is that we are simple people, right? And that's, we don't know any clinical and this, that, and the other. But this has happened, right? And I'll say it, to my family 12 years ago. The same thing that you're going on about, this, that, and the other. There was two options given to us, right? Now, why? Because obviously, thank God, he didn't do anything else, right? Why was we given that option? Because I believe if the option you had with Mr. Calico, right, you wouldn't have released him back out into the community, would you? So is that by law that you are supposed to do that? Because the law wants changing as well, doesn't it? To protect the community. Because you can't put responsibility onto someone else. It's like you as psychologists or whatever are pushing the responsibility back to someone else.
I think that's more of a question outside of their remit, John, to be fair, about law, but I think we quite an evocative subject we're on here. So I've got two more speakers. Next, I've got Mike Adams.
Good morning. Thank you very much for the report. I don't want to focus too much on the horrors of that morning across Nottinghamshire, but I do know that it shocked us all to the core, and I think fundamentally changed my view of the way that I thought my city existed, and made me more fearful, let's say, of the feasibility of people I care about going into that city, and that's at any time as well. The time it happened, I think, particularly threw a lot of us off. We always sort of expect that awful things happen in the dark hours of the night, but some of the stuff happened very early on our way to work, and it was incredibly frightening for all of us. And like I said, it's fundamentally changed the way I feel about my city. And I really want to. The way that I think you felt some of the reactions today from people in here reflects that as well. We've got to do something to ensure that fear is reduced permanently. And as Councillor McGrath said over there, if this has happened before 12 years ago, and as Councillor John O'Lee said, we can't guarantee the safety. What are we going to do to ensure that this is a constant review process? What I fear and what I see existing sometimes in public sector organisations is we get a lump of cash, we go, right, we're going to do something, we create something really good, and we all walk away going, do you know what, that's a great thing. And then systematically over a period of time, that deteriorates. And that deteriorates in terms of the service. A classic example of this, which is not connected whatsoever, is a park. We build a park, it looks stunning. It doesn't get maintained. Then in 12 years' time, we need another lump of money to come again. So we'll recreate that park again, and then it doesn't get maintained. Another 12, we get, and this is similar in this service. I feel that we're just not maintaining this, and we're not the continuation of its good service, of its good quality as it is as it started, isn't maintained. And I fear again, going back to Councillor McGrath's point, that we're repeating history. And my question about this with you guys is how we ensure going forward. I love the fact that CQC are making regular intervention instead of an extended period intervention, because I think that talks to that idea. But what I would like to see within the organisation is a permanence of department, a permanence of section that is responsible purely for ensuring that we are doing what we say we're doing. And that plan that we've got coming up, I accept and look forward to receiving your more in-depth action plan around what we're actually doing to move things forward. I want to see a team looking after that, and I want to see a team coming after the managers in terms of, and when I say coming after, what I mean is sitting down with them in a room saying, are you achieving this at this point? You know, if you go into a private sector organisation, if the share price drops, if customers start to drop off, what tends to happen is you get a response from the shareholders. The shareholders come in and go, well, this isn't right. We're going to change the chief executive. We're going to change things quick before we lose any more money. So in that sense, there's a very direct relation between service and output. What I feel here is the output. If the output starts to fail here, we start to lose lives. This is so much more serious than that, and I think that's why we've got to ensure that you establish something of permanence in your organisation that is that is determined by and probably looked over, I would say, by the public. I think Councillor John Doddy's point around ensuring that we've got a proper public consultation done with this. I actually think you need a public body overseeing a department that fundamentally looks at all of your processes and procedures over time and ensure we maintain that level and we don't drop that level. As I know retention is difficult, and I get why you get a change of staff and suddenly then you can be, oh no, then, you know, Derek used to do it really well, or, you know, Samantha was fantastic at doing this, and then now she's gone, what are we going to do? Well, it's going to take us 6 months to get Tim up to the same level as, instead of that, if we've got a permanence of department where those people are coming, they have to look at that level, they have to be at that level to ensure that the people of Nottingham, and I include myself fundamentally in this, feel safe to have people they care about walking around, going to work. I mean, coming back from a night out, I mean, the stuff that you sort of take for granted, that those people are safe, because, you know, we're failing all of them if we can't do that, and if we can't make the city feel like the great city that it used to feel like before that awful day. Thank you.
Yeah, thank you. First thing I want to say is I'm a very long-term resident of Nottingham. I live 2 streets away from where Ian Coates was killed. I walk my dog often down that street. My my daughter-in-law works at the gym that Valdo Callaghan belonged to, and she was on her way to work just around that time that morning, just going past that street. So I completely understand what you're talking about when you say how it makes us all feel. And I you know, what you said resonated with me, and it's what we all want to. So we're personally invested as well as being professionally invested in taking forward the improvement actions that we've described to get to that point where we can restore that public confidence. In terms of the point about the oversight, I completely agree with you about having a continuation of oversight and making sure that, you know, it isn't. I think in the past, as a trust, we have been guilty of having an action plan after a CQC visit, taking some good actions, but then getting another action plan, taking our eye off the ball of those actions, dealing with those, and not. What we're determined to do is not for that not to be the case this time, and so one of the things that will help us with that is the continuing CQC visits that you've spoken about, but that is also the reason why we've put governance as a programme in our integrated improvement plan, because actually good governance can sound very boring, but if you've got good governance and you've got that kind of proper oversight at all levels, and you've got a proper system of governance that provides that stability. The other one that I would like to highlight is that in Diane's patient safety and quality programme, there is something called being a learning organisation. One of the things that that I think rightly we've been criticised for in the past is that we haven't always learned, and we haven't had that continuous learning, because life never stops still, does it? You have to continue to develop and to learn, and we recognise that that's not been in the culture of our organisation sufficiently, and that's why that is there as a separate project in its own account. So those two pillars, the governance, the learning programme, are there to give that sustainability, that continuity, and that continuous cycle of oversight and improvement that I think you've described.
Yeah, I was just going to talk a little bit about the Safe Now dashboard. So we have a dashboard, I think I alluded to it earlier, which is updated every single week, that teams use every single day. Not only does that tell you about what's happening in your teams and your wards, but it identifies early kind of detection of any areas or anything that could become a problem. So I think that's really important, not waiting until things go wrong, but that early detection and early intervention. In the integrated improvement plan, we've also got a number of rapid improvement groups, which have kind of now become integrated oversight and improvement groups locally, which I chair. So they are we're really looking at these issues, and we're challenging, supporting, and ensuring that things go to plan. Also, we have an integrated oversight and assurance group that NHSE run with partners, and that's monthly, where again we have to present our report, where there's deep dives into certain areas, and where we're all looking at embedding and sustainability. I think also kind of adding to what Jan said, I'm not sure that any of us will forget what happened last year. And I have met with all of the victims' families, including Valdo's family as well. And we have to ensure that that is the moment that changes how we do things and what we do, because we can't go. We can't. We owe it. We do. We owe it to the victims. We owe it to the people of Nottingham and Nottinghamshire to improve our mental health services. And I think we've been completely honest with this. We could and should have done better. There were missed opportunities. We weren't getting things right. And I think that thinking about the why, that is at the heart of our integrated improvement programme. There is no kind of arrogance. There is absolute humility that we weren't doing it right, and we need to. And I do think there is something about making sure that we have more partners involved, more people involved, so that we're hearing the voices of many, not just our own voices.
Yes, and thank you. And yeah, I mean, like you rightly said, where you are, where you live, and what you do, that's the connection, and we all have that locally. And I think if I could just move on the permanence aspect for a second, how are we going to cement these things so that we're not just going through this report process? Is it a case that we need to get it in terms and conditions of employees? What level do we need to go to absolutely level this so that it never goes away? Because, like you rightly say, we will never forget it, fine, but over a period of time, life moves on. People do start to forget things. People do start to move on from the awful atrocities that we see around the world, because, let's be honest, it happens quite regularly in lots of different places, and we all start to become numb to it. And so my feel, I suppose the Valdo story, you know, it's not his story, it's those poor people that it's how we ensure that devastating thing that happened to our city is permanent in the way that we take all of our working lives forward to ensure that we, like I say, cement that in a permanent position within this organisation, so that once our feelings start to dissipate, once we start to care, as things move on, like I say, that we don't forget it, and that we absolutely make sure that this sticks with us forever, and we don't lose it in 12 years, we don't lose it in 5 years, we don't lose it, we shouldn't lose it.
Can I just interject there, Councillor? I think it's paramount that we keep it at the top of the agenda. The conversation continues and decisions are made, and we scrutinise the people that are making these decisions. So I think it's in our within our capacity to keep this at the top of the agenda. Thank you. We've two more questions. Paul, please.
Thanks for bringing me in, Chair. I don't think there's not one of us in this room that weren't touched and saddened and appalled by the events of that's outlined in relation to the killings in Nottingham. But in saying that, we're here to discuss the Trust's improvement or their action plan as a result of their special CQC inspection. So therefore we have to put things in context. Are we as a committee or as a council convinced that the things that are put forward in that report will lead to improvement? Because I think that's a fundamental question. And bearing in mind that the events that happened on that morning are extremely rare. So we have to put it into context that it was a tragic event. Now, if they are a failing organisation, as possibly outlined in the CQC report, I think when I, in my professional life, have been involved with CQC reports and inspections, you either pay lip service to it and carry on, or you see the CQC as a critical friend that are putting things forward that, as an organisation, whoever they are, can lead to improvement. So I would just say, because some of the things that you've outlined to us, I was going to ask specific questions on about things that were highlighted in the CQC report about the communication with families. The family of the perpetrator of the crimes rang up on a number of occasions and expressed their concerns. So to me, that instance is something, the communication between families of people that are ill needs to be improved. So that's just one thing. You've touched on it earlier anyway. And communication in relation to the medication and making sure that the patient takes the medication, that's another issue which needs to be sort of honed in on. If there are staffing issues as well, and you've touched on that you've recruited and it's getting better, are there areas of concern still that you want to highlight to us where there are concerns? When you actually look at this improvement plan, I think as a committee we ought to give the Trust time to implement what they've outlined in this, give the CQC time to continue their assessment, because they will be monitoring improvements, and let's see further down the line how they've implemented this improvement plan, because that is what we're here to look at this morning. Now, Councillor Lee and Councillor Doddy have highlighted quite a number of important issues. Now, perhaps as a committee, we want to add to the recommendations something along the lines that they've indicated this morning. But I don't want to set ears running with this. It's a well-known fact that mental health services mental health hospitals, services have been under financial pressure for some considerable time. Now, whether or not that will improve in the future, that remains to be seen. But I want to give the trust the time to implement some of these recommendations that they're coming to us. Definitely come back to us and discuss them to see where we're improving. With that, I'll end my contribution. Thank you.
Thank you, Paul. Dave, final question, please.
Yeah, I think it's pretty evident that the report, the integrated improvement plan, seemed to, when you're reading it, it seemed to skirt around the Valdo-Calkins issue. And of course, that's prominent in most of our minds because we're all touched by it, as you both alluded to. My son started Trent University last September. So, you know, it's with us all, and it's a constant fear for you as well as us to live with it. I think, you know, that it's good. It's good that the CQC are shadowing you, although I feel really saddened by the fact that it took something like that to get to this stage, and I think that's the real tragedy of it, and it's happening all the time. And Paul, Councillor Henshaw has just alluded to it. I had a series of questions, and it's all right. Hindsight is an obvious thing. We can all be experts in the bleeding obvious when it's hindsight. So, you know, you're looking at what you're doing, your processes. I think we need to be assured and convinced that the processes are going to the ground forces who are dealing with the patients and the people. That's where we need that assurance that what we're actually getting is not just a mealy-mouthed report and actual evidence that it's actually working. You know, because that's the thing. Because I noticed earlier you were saying about you reduced the number of out-of-area beds from 50 to 9, and where are those people going? You know, that's the unanswered question, because those people are intermittently, recurringly ill. So, and it's a problem. And I think the biggest question is, do we have the resource? And that's not your issue, really. It's the government. That, you know, do we actually have the resources to do it? Because I've had a resident who's just come out of Nottingham prison, and I couldn't get him a house anywhere. He came out Monday afternoon, 3:30, with a fiver in his hand. You know, and 90% of those people in there are in there through mental health blips or whatever. You know, they're not. You know, there are issues. He's ended up settee surfing with a fiver. He's living in Bakersfield. You know, and he comes from Jacksdale. It's really a travesty, and that's happening on a weekly basis. And I don't want to say, oh, keep them in till you find somewhere for them to go, because that'd be even worse. But we don't seem to have, nationally, we don't seem to have a pathway, and it's always blokes between 20 and 55, and women as well. Predominantly it is, you know, and I think that's an issue that really needs to be looked at, because some of those people have had psychological assessments before they even ended up in there, you know, and that's another pathway that we need to look at. But my biggest concern is, do we have the resources to fund what we're doing, you know, and that's NHS England, I presume, isn't it? And the integrated care board part of that.
Yeah, I think all we can do is to iterate that however financially challenged we are, we're not compromising on clinical staffing. You know, clinical staffing is absolutely important. In terms of the beds, I just wanted to provide some assurance, I guess, that the improvement in the position has been through a lot of hard work with a lot of system partners to ensure that people who are in hospital, who don't need to be in hospital, have got somewhere to go, and we do have an exit, and that has improved that horrible word flow, which has enabled us to get to where we need to be. But also we've just had more rigorous oversight. We've just had a lot more rigorous oversight daily about where people are going, and ensuring that where they possibly can be placed in a placement within the county and the city, that they are doing so, because it's not good for people to be sent, you know, away from their home area. So that's been the nux of that matter.
Thank you. It's hang fire a bit, John, because Roger, I know you want to say a few words, and if you would please.
Yeah, thank you, Chairman. Yeah, and my apologies, I was a little bit late joining this debate, and I thank Jan and Diane for coming in this morning. The things I picked up on is that after a very damning CQC report, things are slowly picking up. You know, and then, but you know, you've got your action plan, you've got an integrated improvement plan. But I think it's important, the questions that come from this committee this morning, that we invite these ladies back again, probably early in the new year, to see where you are with this plan, please, because I think it's important as a committee we know how you're progressing. Because I know you're under a lot of pressure from outside, you know, from things, and you're under budgetary pressure as well. So it'd be interesting how you're dealing with that as well. So I think if we could, Chairman, invite them back. Yeah. Thank you.
I've got down January 2025, where if you can bring your action plan back to us, I think we'd all really appreciate that.
If I may, Chair, if there are any particular issues that the committee would like us to focus on, we can give a broad brush, but if there are any particular areas that the committee would like us to really do more detailed work on, we'd be very happy to do that.
With that in mind, members of the committee, if you can get in touch with Catherine and forward those any particular issues, concerns, etc. that you have. I think we can draw this this agenda item to a close, and thank everybody for the contributions. Particularly thank Diane and Jan for your attendance, and we'll just take a 10-minute break if you don't mind before we. Oh, sorry. Yeah. Sorry. Yeah, we've got some recommendations. And that we accept these recommendations. One is that the progress taking place in respect of the improvement plan is noted, and two, that further update regarding progress from phase 3 of the improvement plan be received at an appropriate time.
And Councillor Turner, we said we would review the transfer the PICS contract from PICS to the ICB.
Can I have this conversation? I think,
but it is a recommendation. And even if you don't want to follow it, it still makes it a recommendation.
We're already having the conversation.
Yeah, it's in the recommendations.
Yeah. We're gonna look at it.
Okay.
Yeah.
So yeah, thank you very much for coming. We'll have a 10-minute break and reconvene about 10 to midday, if that's okay.
People vote on the recommendations.
Oh, we need to vote on the recommendation. Sorry. Yeah. Do we need to vote, or we just noting it?
This is the recommendation that they bring it. It's all right.
Yeah, we're on. Yeah, we're bringing it back. We're bringing it back.
I don't think anyone objects to. I didn't hear any objections. So.
No, we're
okay.
Can I just?
I think everybody.
Lucas, we're ready to resume. Thank you. So, item 5 on the agenda is achieving financial stability in the NHS. Both last item and this item can be linked to a degree. I'd like to welcome Maria Principe, Victoria McGregor-Riley and Alex Bull to the meeting today. At the previous meeting it was agreed that an update will be requested to give additional context around the decisions that are being made, specifically the impact of the decisions. I know that the report before us today does give additional context, but it is silent on the impact of specific decisions, so could the introduction please give us an indication of when this information will be available? Can I invite you to introduce the update report, please? Thank you.
Thank you, Chair, and good morning. It's just still morning, isn't it? Yeah, good morning, colleagues. Really good to be here. So I'm just going to speak for a couple of minutes and then I'll pass to my colleagues. I was here, as Councillor Turner said, in July alongside Lucy Dadge. So Lucy has moved on to a new role within the NHS. So today, Maria and Victoria are here to kind of pick up the thread of that conversation from July, and I'm here to offer a bit of continuity as well. So Victoria and Maria, do you want to just introduce yourselves as well before we get into it?
Hi, I'm Victoria McGregor-Riley. I'm the Acting Executive Director for Strategy and System Development within the ICB. Hi, I'm Maria Principe. I'm the Acting Executive Director of Delivery and Assurance for the ICB.
So just as a reminder of the context in which we're operating, it's really important that we remember that funding levels for the NHS here in Nottingham and Nottinghamshire are increasing year on year. I think that's a really important kind of starting point that we need to keep in our minds. Funding is going up for NHS services here in Nottingham and Nottinghamshire. But the costs that we're facing and the demand is growing as well. So we have a duty, we have a legal requirement to live within our means. As part of that, we've agreed with NHS England that we are allowed to overspend our budgets by £100 million for this financial year. So effectively we have been allowed to spend more than we would usually or be expected to be allocated. But even that means that we have to find about a 6% saving all across the NHS this year. That's in all parts of the NHS, whether that be the hospitals, community services, general practice, across the board. We've got to find about that level of savings, and that still means that funding, spend is growing for us. And then for next year, so the financial year that ends in March 2026, we have to be in what we call financial balance, so no overspend at all. So there is, I'm labouring this point because it is really important that the funding levels are continuing to grow for NHS services here. But because of the demand and the costs that we're seeing, we are having to adjust our spend and find ways to kind of manage through those expectations that are set nationally.
Chair.
So if we have the next.
Can I have a point of clarification there? You give a percentage of what you need to reduce it by. There's no percentage in terms of what you're saying was the increase year on year. Do you have a figure for that?
Not to hand, I'm afraid, but I'm sure we can provide that. So if we could move on to the next slide, thank you. So back in July, we shared a list of schemes that we were working on at the time, and that was done very intentionally to give the committee really clear visibility of all of our thinking. We want to be transparent, we want to work with you, we want to give you the information so that we can work together to deliver the right solutions, the right decisions for our citizens that we serve between us. Since then, though, as you would imagine, we've refined, we've developed our approach, we've refined that list. And our approach throughout and ongoing will be to protect frontline services as much as possible. So right now, we're maximising efficiencies, we're looking for productivity gains, we're controlling our kind of financial spend, looking at all our contracts, doing all of that, maximising all of that before we consider any other kind of options that might have more of an impact. So what you've seen before and what we'll be able to talk about mainly today is in that kind of business as usual efficiencies type work, and colleagues will be able to kind of unpack a bit of what that means so that you can really understand it. We are currently exploring some more kind of transformational changes, some things that might have a bit more of an impact. We do not have that information with us today. To your point, Councillor Turner, when we have that, our commitment is to bring that to you as quickly as we can, to give you the opportunity to really probe and understand and contribute to our thinking on that. But that's not what we have here today. So Maria, I'm going to hand to you. I think you're going to talk in a bit more detail about that kind of efficiencies approach.
Yeah, so if we could go to slide 5, is that okay? Because I think Alex covered some of the high level views and we'll assume that the papers have been read. So what I wanted to do is just go through with you some of the general areas that we're doing around efficiencies and savings, and how we're trying to minimise that impact. Although, as we have recognised this morning, there are some uncomfortable conversations that we have to have. We do have to achieve financial balance. So some of the business as usual ones is around prescribing. Year on year, we know that we have a lot of our medications and our reviews that we do, and we buy medications on patent. When they come off patent, that means they become cheaper. That means other organisations can buy them. And we do that year on year. We buy and swap different medications, which is why sometimes your constituents and your clients or our patients will see different boxes. We're trying to buy cheaper and make the most out of the money. What we're also trying to do is look at our software and our licenses. One of the areas that we're doing again that won't have an impact on yourselves but does see some of those efficiencies saved is around text that we send out to some of your constituents and our patients. So we pay by the number of words a text goes out. Sounds crazy, but what we're trying to do is reduce the amount of words when we send out a reminder to patients. So instead of going over 1 and 2 screens, it'll go over 1, and we're trying to reduce that down. These are ways that we can try and do efficiencies. Software licenses and updates. Do we really need the latest license? Do we need an update? Again, that is something that we're currently looking at and doing. When it comes down to contract consolidation and administration, what we're trying to do is look at lead providers. And I will talk about this. The any qualified provider route was fantastic for choice, but ultimately it created lots of providers in the market, and ultimately those lots of providers had lots of overheads. And what we're trying to do now is look at where we can consolidate, have one provider lead multiple arrangements, reduce some of those back office functions, those management functions. We're also looking at how we consolidate prices. We have some providers who are charging us different amounts of money, and what we are doing is saying, look, this is the price is the price, and we're going to have to bring it down so everybody pays the same. And again, some of those are the approaches that we're taking. We've had some national monies, so the service development funds, and we're given this from national peeps, and it's non-recurrent money, so it's for a year, and what they say is, can you look at and invest in this? And what we're doing is we're now saying we are going to look at what we're currently investing in. If this duplicates or adds a layer, then we're going to defer that payment. We're going to hold that back and look at where we can invest. And some of this is where actually it stops some of that chaos sometimes as well, because what we're trying to do is rationalise some of those health services that we have. We are looking at where there's national investment and where we have to invest, and what we're saying is we're investing our amount that we need to do, and that could be in the better care funds or in some of the other services that we have, and say that is the amount that we need to invest, and we won't be investing more, but we won't be investing less. And so it's how we look at our investment into those areas. And then there are other areas that we can do is adherence to eligibility policies. So we have something called the best value policy, and these are clinically endorsed policies that say our patients should not be having this unless for this reason. And we do know that in some circumstances, patients seem to be getting on the waiting lists. And what we need to be doing is going back and reinforcing that policy, because it's in the clinical best interest of the patient not to have that. There's also what we're trying to do is maximise national income. So the Elective Recovery Fund is a national programme since COVID that the government's been given to try and reduce waiting times. And what we're trying to do is, and we get investments for reducing that waiting time. And what we're trying to do is optimize that to try and get the most in to try and generate income. So again, we can stop the impact on frontline services. So that's just a few of the services and our approach that we're trying to do that minimises the impact on our population and our cohorts. However, as Alan says, as Alex says, this is for this year. For next year and the year after, we've got to revisit those agendas and again look at what else we can do. We've got a very challenging financial situation that we have to address.
So I just want to talk to you a little bit about the processes that we've put in place to make sure that the decisions that we make are as effective and the best decisions we can do to make sure that we achieve both financial security and resilience, but also make sure that we deliver the care that people need locally. And you would expect us to, and we take that very, very seriously. So part of the reason why we've not been able to give you a lot more detail right now is because that process is one that's very, very carefully, thoughtfully progressing, and you wouldn't want us to rush that. You would want us to take into consideration a whole range of views and considerations in order to make that decision the best we possibly can. So that's part of the reason why we aren't able to give you the level of detail that I'm sure that you would all like to see quite quickly. The process itself includes an initial consideration of the ideas and the opportunity. Every stone is being unturned. Every single opportunity is being looked at so that we can make sure that every single penny that we use is used to the best possible effect. So from initial idea and concept, we'll go through to a desktop review, looking at what does the evidence suggest, what does the clinical advice suggest that we do, what are we currently commissioning, how are we contracting for that, does that offer best value, are we meeting our statutory obligations and our duties. So there's a very comprehensive rounded review of every opportunity before it goes anywhere near a formal decision making process. So part of that is what's known as an EQIA, that's an equality, quality and impact assessment, and that is a very rigorous process that we've tested with legal advice, and that considers a whole range of things around the quality of the service provision, the equality of the proposal, the impact on health inequalities of the proposal, and other things like the data protection and data confidentiality. So it's a very rounded, very considered process. We have then got a decision-making process at the end of that, which is an internal governance arrangement. But we've also now established across the system an oversight group that comprises of different partners, and that is looking at the totality of the impact across not only the ICB's proposals, but also those of our partners, so that we can understand what is the impact of this in the totality across our system. That's still emerging as a process. Obviously, this is new to all of us to try and get this rigour in the process. So they've had one of those meetings so far, but we will be continually reviewing and making sure that that process is robust, both internally within the ICB, but also across the system as well. And obviously coming here and explaining the progress of that will be really important, and having your input as we go through. So the last slide that we've got just outlines those key stages of what we do as part of the process. And hopefully over the next period of time we can come back and give you the detail that I'm sure you're really, really keen to hear more about.
Thank you. We kept it brief, but really happy to have whatever questions you've got.
Yeah, very emotive subject, the NHS, and it's funny how the older you get, the more emotive it becomes. Open the discussion to the floor.
Thank you. Yeah, I just want to have I'm IT based in my career, so when you start talking about software licenses, alarm bells start ringing in my head. This obviously, I'm sure you are reviewing this in the right way, but ransomware, malware, antivirus, let's make sure they're all up to date. We don't mess with those licenses at all. We know obviously in recent times there's been quite there was a few incidents, I think it was a couple of years ago now, where ransomware was used on NHS computers within surgeries and caused a lot of issues with regards to that. So I'm sure you're all over ensuring that safety and security of the systems are up to date. Just really in terms of the overall, I suppose one thing that's crossed my mind, I know Anthony May was in here talking about, I know it's QMC, but we're talking about the the new renewable heating system they were installing, and putting these very deep piles into the ground to generate, I think it cost 80 million quid, but it would effectively over time pay for itself and then start to be almost a cost efficient, free, if you like, to a degree, system. I'm just wondering on that element, how as the challenges grow in terms of the costings of things. I know I saw you think about tablets and things like that as medicines, and how you look for the non-patent versions, which is great. I'm glad to hear that. But I wonder how as costs grow, where are you looking for things like efficiency and things like stuff that you can use in renewable energy and things like that to reduce overall costings? I know that there's lots of arguments about whether we should still be coal-fired and stuff like that, and I take that, but I think it's almost a free hit in terms of if you're in a public service to get something like that, because I assume energy must be one of your biggest costs, if not your biggest. I would have thought. So just really on that, what's your plan for that, and over what sort of time period are we talking about? Do you plan to have that in place to resolve that energy question?
I think you might get all three of us on this, because I think we're all really passionate about this, and I think you're right, Councillor Adams. It's a really good example of where investment now, which sounds like a really big amount, pays back really quickly. People is probably our biggest cost, of course, but yes, energy will probably be kind of second, third on that list. I wouldn't be at all surprised. It's a really good example of national funding that we've been able to secure as a system. So it's an even sort of freer hit than you might imagine, because that's kind of we've been able to kind of bid and secure that. And yeah, those ground source heat pumps will make a real difference in the long term. I'm hoping that Maria and Victoria might want to talk a bit about perhaps our joined up estates work and some of the other things that kind of link to that.
That's not something. It's not an agenda that any one organisation is going to solve on their own. This is about how do we collaborate and work together to create the economies of scale that we can around this. And obviously, there's a key agenda item around the new East Midlands Combined Authority as well on this agenda. And we know obviously that the fantastic work that's happening in Bassetlaw around the different nuclear energy options as well. So in terms of the provision we've got as an ICB, we ourselves obviously have energy costs, but we're a relatively small organisation where the opportunity really lies is with our provider colleagues. That's where, the big estates, big infrastructure. And obviously individual organisations are doing things in the way that you said, but what we're also trying to do is creating the collective effort as part of what we've got as a joint forward plan. And the responsibility of the ICB in this space is also supporting the wider terms of healthy economic and social regeneration, that kind of fourth aim as we call it, and really trying to galvanise our partners as anchor institutions to say, in combination, what can we do together? So there's a real opportunity of the agenda. I don't think we've done enough in this space, but what I'm really hoping is over the next immediate period of time, as part of our strategic development, we can galvanise a collective effort about what we're going to do in Nottingham and Nottinghamshire to support our net zero commitments, which we've all made as organisations. So absolutely continue as individual organisations to do what we can. We've got an internal ICB arrangement around net zero and what we can do, things like flexible working for staff, encouraging non-car use, that kind of thing. But that's the tip of the iceberg around what the opportunity is. So I hope we can take that forward, and obviously working with yourselves from a county council point of view will be part of that partnership arrangement as well.
Yeah, I think just come back on that for a second. I think what, and I suppose this is why I brought this up in a financial item, and I brought the same question to Anthony as well. That whatever we invest in, because we're doing it with public money to achieve that, we've got to make sure the public are getting a return.
Absolutely.
Although we're all focused on trying to improve the breathable environment, if you like, for everybody that's around it. By the same token, we've got to ensure that when we are spending public money, that we're getting a return over a period of time. And there is a period, once that has been paid off effectively, that then we are seeing those massive changes in our budget top line. We've seen in Nottinghamshire County Council with street lighting, we did the massive rollout of LED lighting, which has saved us millions and millions. There is that initial cost investment, no question, over their lifetime. That will pay us back and pay us back and pay us back. And it's having, I think, that foresight sometimes to actually go with something like that. It's relatively low cost in terms of a per street lamp item, but then over that lifespan, it can make such a huge difference. So yeah, I'd love to hear about that, and I'd love to also for the publics that their money is being spent on. I'd love it when you guys release press releases about this, the front and centre of that is what your investment is, what the public's going to get back over its lifetime. I think sometimes, and I agree with them actually. We can be, as public organisations, so focused on the environmental side that actually the cost benefit isn't highlighted enough, and that's the thing that affects people's pockets. Things that people really care about. They want to make sure their money's being spent well. So that would be my only ask. That when you talk about those press releases, let's get a financial return. It's going to take 10 years. It's going to take 10 years. Yeah. It's going to take 15 years. But let's make sure that's there, so that they understand that their money is being spent well. It's not just being almost felt as a woolly item. If that makes sense.
Can I just, because I absolutely agree with you, and that's right. But although money is really, really important, what's really also important, if not also, is that our health and well-being of our local community is improved by those alternative opportunities, cycling and being more active, not jumping in your car to go 3 miles down. So those other things are far, far beneficial for our local community from a health and well-being point of view. So that needs to be considered as part of that broader cost-benefit analysis as well. It's not just about the money, it's also about people and improving the health and well-being.
Thank you. Councillor Martin.
Yeah, thank you, Chair. Well, I wish you all the best in saving money with the NHS, because it must be an arduous task in itself. But the thing I'd like to pick up on, Alex, is something you said about the 25-26 budget. You're going to get 100 million, and then thereafter you're not going to get any. Is that because that 100 million has been allocated by the previous government, and you don't know what you're going to get till after this next budget, or is that something totally different? The other area as well that we could save money in without investing in new stuff is things like the PFI contract on Kingsmill Sherwood Forest Trust Hospital, because that costs them over £1 million a month, and it's just phenomenal. And they're also tied into maintenance contracts, and it doesn't include the back of the hospital; it only includes the front where it's new. Just like all fur coat and no knickers, really, at the back. It's something that really needs looking into, and I think that is something that would endear the people from Newark and Sherwood as well who come over to Kingsmill, because that's the real issue. And I think it's looking at cost efficiencies in existing financial practices that could also contribute towards your financial shortfall, which I'm sure Alex is going to fill me in on now.
Thank you, Councillor Martin. I'll pick up the first point, and then colleagues might want to come in on the PFI. So just to be clear, for this financial year that ends in March, we've effectively been given a kind of an agreement with NHS England, rather than the government, with NHS England, that we can't overspend what we should usually kind of receive according to our population and the age and the demographics of our population. That isn't being offered for next year. So for the year ending March 2026, we have to live within our means and spend the money that we've been allocated. That's not particularly linked to kind of governments or changes of government or anything like that. That is about our relationship with NHS England and the kind of national spend that the NHS has, and we have to live within our means. That's the overriding kind of expectation. PFI, Victoria.
PFIs were an initiative by a previous government, weren't they, to support expenditure and capital, big growth, big buildings and things. I'm going to be keeping it really simple. I don't mean to do that in a patronising way, but it was, they were undertaken at a point in time. Those contracts were agreed. Those were the arrangements that were agreed. And I'm sure that there is every effort being made by our provider colleagues to make sure that they are as least troublesome in terms of ongoing repayments around it. But that's kind of the arrangement that was made. Those contracts are in place, and that's about how we manage them moving forward. I get the point, and I also know that obviously the government is really looking at and reviewing how they support capital investment in the future as well. It's going to be a big, I think, consideration in the next period of time. I would give you the assurance that every opportunity to try and create efficiencies is being looked at across everybody in the NHS organisations at the moment. It is not something that we are taking lightly or regarding as something that is secondary to our business as usual. It is absolutely business as usual. Every single penny is being reviewed to make sure, are we spending every penny of NHS public and taxpayers' money to the best effect that we possibly can. That will include whether it's PFA, whether it's estates, whether it's digital and IT, whether it's frontline services. Every penny is being looked at. I want to give you that assurance. which is why, going back to the presentation, the process of that consideration needs to be really robust. And we need to be able to come here and give you the assurance that we've thought about those decisions in the round. But make no mistake about it, there will be some very challenging conversations that we'll need to have about making sure that in that decision making, we're going to have to prioritise how and where we put those resources. But please be rest assured, everything has been looked at, and there is a whole estates, as well as everything else, efficiency programme and being tracked to make sure those decisions are appropriate.
And to add and to answer Councillor Adams, so I'm looking at a spreadsheet now in which we, as Victoria says, we track all of those efficiency savings, and finances are that tight that we're going after everything. So I can see things on this spreadsheet here where when we're talking about energy and efficiency savings in Sherwood Forest Hospital, we're looking at £250,000. Can we try and invest in that to try and get that money out? With regards to the maintenance contracts, we have hundreds of maintenance contracts across all of our providers, and we're looking at renewing them, reshaping them, anything from 19,000 up to 126,000. We have hundreds of these on our list, and what we're doing is going through them systematically, seeing what we can do. As councillors, what you'll do is you'll hear the outcome of some of that, some good and some bad, because we're going to have to do, and I keep saying it, the uncomfortable decisions, the uncomfortable approaches we're going to have to do. But the financial environment must, we have to do that. So yeah, it just going on the back of what Victoria said, it's that assurance that we are looking at that. We have hundreds of maintenance contracts across our system, and we'll be reviewing every one of them and looking at the energy and how we can save money before we have to look at the impact that this has on frontline services.
Thank you. Councillor Lee.
Chairman, thank you very much. So, as a declaration, obviously I'm an amputee, so I use the services. However, it does really concern me that you're talking about cuts in an area where you are already failing, in areas where you are failing. The maternity review, you failed. Mental health issues, you failed. If anybody gets the time to go and have a look at the amputee services in the city, they are shocking. To the point where I've wrote to the MP on more than one occasion asking for more investment. If you went there, it looks like it's back in the 60s, where they have multiple men in the same rooms, changing together, putting limbs on, something I've complained about. But let's come away from that. Only a few months ago did we have somebody here saying all the investment you've done for Newark and all the services you're bringing into Newark and everything, and it's a jewel in your crown. Will you, and I'm going to add more questions to this, are you able now to say there will be no cuts to Newark Hospital with services or times? And then I'll come back to you.
We cannot say that there'll be no cuts, but I think what we also can't do is confuse investment with quality. And I think that's something that we have to address. So just because we invest in money doesn't necessarily mean we receive the quality that we expected. And also because we're disinvesting in some services or may, it doesn't mean that that will impact on quality either. I think what we have to do is address the two very differently.
That's not the question I asked. I asked, are you able to say you're not going to cut services in Europe? We know that that you would prefer, and please tell me if I'm wrong, to supply services elsewhere than Europe, because you've already cut the service, you've already cut the A&E, you've already cut the services that you're meeting elsewhere. The concern with residents and myself as elected councillor is you will use this as an excuse now to cut services in Newark and move the services elsewhere. It already takes residents, something that I argued last time I was here, it can take them up to 45 minutes to get to Mansfield in an emergency at night time when you need to get somebody to A&E. We're already fighting for better services in Newark, and now you're not able to say that you're going to cut services in Newark. Now, my colleagues are going to hit you on other areas, in other hospitals and other services. We already have failing doctor surgeries, we can't get appointments. We're already having, as I said, mental health issues, people not being able to get mental health, and you're talking about cutting services. You need to be investing in services, not cutting them. And then you talked about net zero. Unless it's saving money that you can put back in the service, scrap it. The residents will not thank you for doing net zero if it means the cost of services. They're not going to thank you for it, and I will not thank you for it. Services must come first. Unless the net zero means money goes back into services, they're not going to thank you for it. Services have to come first. Your first job is to treat people, not to save the planet, is to treat people. We can have a planet, but the people won't be here because you've not been able able to save them. And I'm sure John Doddy will jump on that later. I'm going to stop there, Chairman, and I'm going to let them answer the questions.
Hi. Yeah, there has been considerable investment in Newark, and I don't see anything that's suggesting that we're not going to continue to deliver the services the patient needs in Newark. I think what Maria is alluding to is the fact that we've not mentioned cuts at all. What we've mentioned is efficiency so far. And what we've also articulated is in this financial year, our focus is where we know that there are opportunities around reducing inefficiencies, wasteful use of money, duplication, lack of coordination, making sure that we get the best value for every pound that we've got. In all those transactions, there's nothing about cuts, and there's always an emphasis around efficiencies, but where the quality to patients is not reduced, and that has been, and patient safety is not reduced. So we will continue to commit to provide the services that people need, whether that's Newark, Mansfield, Worksop, in the middle of Nottingham, wherever it is. But we also have legal and statutory responsibility to make sure that we achieve that financial balance. So that also has to be tempered, whatever we do, by that also our statutory duty on that. So that's where, if there are going to be any significant changes, that's the conversation that we will obviously bring back here and have further conversations with you about what they could possibly be. And it will involve patients and people in those conversations where any significant change is proposed. So you will be fully informed and able to contribute to that conversation before the decisions are made.
Well, to be clear, yes or no, are you able to say here now that there won't be any cuts to Newark?
I'm saying that we will continue to fight for efficiencies so that every penny of taxpayers' money is used to the best effect. But I'm not going to suggest.
Chairman, could you ask them to answer the question yes or no? Is there any cuts to Newark? That's what my residents
I think
want to
I am
hear.
trying to answer the question.
I can do that. I can answer that. It's no, we can't say that we'll never do that. No, so that's the answer.
Thank you.
I don't think anybody can. Councillor Doddy.
I think you can say with definitely if you're not going to cut something there, Chair. I think it's perfectly reasonable to say that you're not going to cut something. Yes. But fluidity is caused by the people who cause the fluidity. So if you don't cause the fluidity, you haven't got a problem. But
and people
there is no guarantee, Councillor Lee, that you might not even have a New York hospital by the time you get home.
I wouldn't be surprised.
You would be surprised. In any case, yes, I think there's some great stuff being done by the ICB, and yes, I see it every day. And this pulling back into the system fragrantly wasted money on different brands of drugs, etc. It makes absolutely perfect sense. And against the background of an extraordinarily financially challenging service that we've got, it's this type of efficiency that prevents us having to do the healthcare cuts that none of us actually want to do. So I think that I see that work happening every day, and I know it happens. In terms of the ICB itself, obviously on behalf of health and wellbeing, and you sit in the ICS along with the ICP and the Health and Wellbeing Board, etc. And we're committed to a 3% amount of money put through into preventative care so that we can improve place-based partnerships, etc. and reduce diseases, as the prevention of illness is the cheapest way to manage any healthcare system in the world, as opposed to dealing with the consequences of that, whether that be obesity and diabetes or whatever. Certainly in my previous role, the reliability of the ICB, shall I say, to actually come up with the money to maintain the preventative agenda was not necessarily guaranteed, a bit like New York. It was hoped for, and I think it was largely hope, but I'd really like to see that the preventative agenda wasn't a casualty of these costs, but it may well be. I think it's interesting when you look at the efficiencies that there are very few efficiencies that don't create knock-on effects, and the ICS is a series of dominoes that when you hit one, then it all goes all the way around the system. And some of the things that are happening out there have a direct effect back into people's communities. And I think that's very important. I'm going to highlight one specific area, which is the Queen's Medical Centre Neurology Department. My secretary told me recently, in all the referrals we've done since January, only one of them was given an appointment. Everything else was rejected. Please send to cardiology, please do this, please do that. The most unusable service in the history of the NHS is the neurology service. That's backed up by probably every single GP in Nottingham. One referral, every other one was rejected. Just say if I send somebody with pins and needles in their hands and feet, I get a letter back that says, we never find out what causes pins and needles in people's hands and feet. Could you give them some painkillers? And that is the reply. And that, I'm not making that up. You couldn't make it up. It's that bad. But that's the type of, that's that 99% of what comes back from neurology. I have no idea what's wrong with this patient. Give him some painkillers. So I highlight that just as one case of a knock-on that it seems like a deficiency, but it's not. On the other hand, it is very reasonable that the public don't always understand, and you are going, Victoria, you're going into this a little bit, that what they're actually entitled to. And I'm going to just give you one example how we're using very successfully Wegovy in, which is the weight loss drug in diabetes. But the amount of the public that really want us to use it in obesity, but we're not actually allowed to use it in obesity. So there's some fantastic things that we could be doing with our money to improve the health and well-being, but oftentimes the communication to the public isn't there that allows them to understand what we're actually providing and what we're not actually providing. And just to finish, that the NHS is a buffet. But what's happened over the last number of years is the number of items on that buffet continues to get smaller and smaller and smaller. So they can still say, welcome to the buffet, but you're not going to get well fed.
But the appetite continues to grow.
The appetite is growing, correct.
So can I just say one thing and then I'll hand to colleagues? There was a little bit of mischief making there, which I don't think is helpful for our population. So we need to be really, really clear. The ICB, the NHS in this area is absolutely committed to Newark Hospital. It is and will continue to be an important and vital part of the health and care landscape in Newark. So members going around saying, oh, there might not be a Newark Hospital, that's not helpful. And I think it's really important that we stick to the facts here. Colleagues.
Just in terms of the prevention agenda, Councillor Dodd is absolutely spot on. It is one of the things that we absolutely do need to continue to support as much as possible, whether that's primary prevention and the wider determinants of health, education, employment, housing, etc., working absolutely in partnership with County Council and the City Council and other District Council colleagues as well, which we will do and continue to do as part of our place-based arrangements, and or whether it's secondary and tertiary prevention, as in when somebody's already poorly, how do we stop them getting worse, how do we stop the exacerbation? And place-based partnerships offer a real opportunity for us to continue to do that. And obviously, we all want to make sure that that investment in that prevention agenda it continues as much as possible. But I'll go back to that will be one of the considerations that we have as part of our overall totality consideration, the opportunity to make the savings that we need whilst not diminishing the quality of care for patients locally.
And I'm happy to take the neurology question away. I'm just looking at data. We had 463 outpatient activities for neurology last month. So it'd be good to see where that is a challenge for you and we can take that away and have a look at that.
Be good to see what the activities were.
Thank you, Councillor Dodd. Councillor Wilmore. Oh, sorry. I told Councillor Eddy.
Yes, sorry, I thought you put your hand up for me there. I'm going to echo quite a lot of what Dr. Doddy said. And Victoria, I was really happy when you brought it back to people, because when we're talking about money and savings, we forget that it's the people and our local communities that are going to be really affected by whatever the services are. So I suppose my big ask, if we talk about cuts, is to make sure we really communicate with residents about what is happening with their services and really make it clear why things are happening, because I think people do understand. I totally agree with medication. If we can get it cheaper, we should do. But I do worry that changes in services will have implications further down the line with other partners and other services. So that's one of the major things. But also totally agree with John about prevention. We've got to make sure that is key in all that we do, because otherwise we're just going to save this time but have a huge bill down the line. So I think it's one of those things, but thank you for making it about the people, because I think sometimes when we have reports and it's all about money and saving money, we forget that it's about the people using those services.
It's always about the people, and if we ever give an impression that it's not, hold us to account on that, because it is about our people, it's about our communities, it's about our families. You're absolutely right. Prevention, I've already touched on, absolutely agree with you. The involvement and the opportunity to engage more generally with our local population is something that we are exploring at the moment. Again, I absolutely agree with you. I think the local taxpayer, our local communities understand the straits within which we operate. They understand those economic challenges. I mean, you pick up a newspaper, listen to the radio, it's everywhere. Everybody understands that. And I think everybody acknowledges that we're going to have to make some choices about the priorities, about the way that we spend money. So I think that engagement and that involvement is really important, and it's something that we're definitely taking on board. I agree with you. And I think as part of that, being authentic in our quest around, we want to give our people the best opportunity to maximise their potential, their health and well-being. We're all in this because we have the same intent and the same ambition for our local community. We may take different views about how that prioritisation happens, that's fine, but that's about having that open, honest and transparent conversation. So I agree with you and fully support the comments that you've made. Thank you.
Thank you. And now we're Councillor Wilmot, please.
Well, thank you, Chairman. It was enlightening on the Sky at Night last night that it said that in 5 million years' time the Earth will not be able to be lived on, which was an incredible statement to make. But I have great sympathy with the NHS. They clearly do not receive enough resources to do the job properly. It is getting more difficult to deliver the necessary services and the priorities to the service within existing available resources. And it will get worse, which I will comment on later. It's not what's in this report that concerns me. It is what is not in it that concerns me most of all. Members of the committee will know that since July 2023, I've been consistently pushing for support from this committee for the NHS to deliver the promised Super Health Centre in Hucknall. This is one of 6 projects under a national pilot scheme to create 6 super health and wellbeing hubs, also known as the CAVL centres. This remains on the work programme for this committee, but despite several requests, it still has no date allocated. This was halted by the NHS England due to a lack of capital funding at the time. Hucknall had been shortlisted as one of the 6 national pioneer projects for a new all-under-one-roof community hub concept aimed at supporting the health and well-being of the local population rather than just treating illnesses. This would have been a game changer for them, no doubt about it, a game changer for them and the area around it. Residents are living through a healthcare crisis with poor access to healthcare. Ashfield District Council have committed over £1 million for the project, which was set to be on West Street in Hucknall on the site of the old 7 Stars pub, which is still derelict, and I get requests every day on the position of that derelict area, the condition of it, absolutely disgusting. Could the Nottinghamshire Integrated Care Board inform us where we are with this crucial health hub, reconfirm your support for our Super Health Centre and provide an update to this committee on what additional services we will be receiving in the interim. Now don't forget, since it first thought of this CAVL Centre, the population in Hucknall has increased by 5,000 people. 5,000 people. So we're having to deal with 5,000 more people with still the same services. And there is hundreds of homes up for being built in the next few months, especially on the outskirts of Hucknall.
So,
An incredible situation. I'm saying the pressure that the services are under in Hucknall is astronomical, and some observations that many thousands of people signed a petition in 2019 for this project, but have been ignored. Now, if you look at the services,
John, can you just?
Yeah, I'm finishing off now. Yeah,
parochial.
Yeah. You say that you're assessing the impact on patient care at this present time, but the problem is that there are hundreds and hundreds of houses to be built in Nottinghamshire in the near future, which will put your thoughts behind, out of date. I just wondered whether you have assessed that situation and of the house building, which is going to be a major problem to support the people in their quest to find services for health. Thank you.
I'm happy to see. Yeah. So, thank you, Councillor Wilmot, and your commitment to the delivery of primary care services to the people of Hucknall is steadfast and long-standing, and you're a real advocate for your community. There is no further update on what you refer to as the Cavell Centre. That programme does not have the national funding that we would need to deliver that, but we continue to invest in primary care within the Hucknall area. We are increasing some of the clinical space within the existing practices with support practices there, and we do continue to monitor the growth in population. That's one of the key benefits actually really of working really closely between the NHS and local authorities, because it's only the local authorities, the planning authorities, who know what that housing looks like. So we absolutely do build in those housing developments and the forecasts as part of our population kind of assessment of need. So no, the idea that we'd kind of be planning and then suddenly a load of houses would emerge in the pipeline that we weren't aware of won't happen. We are looking forward and kind of working with local authority partners to make sure that we're capturing that future demand as well. Victoria, I don't know if you want to add anything.
No, I think that's covered everything, and obviously I commend the commitment that you've got around ongoing support for primary care in Hucknall. But as Alex has already indicated, I'm aware that Cavell initiative isn't something that we are actually pursuing at the moment. But if there's any further detail, then we can obviously give that to you outside the meeting if you'd find it helpful.
Thank you.
Can I just say, can we have some commitment that this situation will be discussed in this chamber at some time in the near future? Because at the moment, as I say, it's been now 3 years. 3 years. I don't know of anything else that's been held up that long.
John, can you
thank you
to Roger and myself outside, and Catherine outside the meeting? Thank you.
Thank you very much, Chairman. I suppose just in terms of this entire item, I know we talked a lot about the specifics actually in the last meeting in July. Some of the more programmes and such, for example, the issue with the savings when it comes to the mental health investment review. So that's what, 3.1 million. So a lot of those big projects I think we've already discussed in July. I suppose the big concern for this committee, I think what you brought in the report, is the difference between Group 2 and Group 3. So obviously the Group 2 is we're talking about minimal change to services and for the for the person. I think Council already put it quite well when it said people don't care if your medicine's cheaper in the background. It's software for people. That I expect that. I expect you guys to be making these savings without us having to look at them. I mean, councils across the country have been doing this for years, and when you're coming to us with 100 million, it's a lot of money. I'm very surprised that you're only just making these sorts of savings, these easy savings now. But the difference between Group 2 and Group 3. So I suppose our concern is those items just in July. I don't want them to be slipped into Group 2 when actually they're Group 3. When we're talking about impact services, although you guys may go, well, it's not that big, it's minimal change. It may be on the ground, and for us, it's actually a big change. It's a Group 3 change, that requires us to keep an eye on it. So without going into the the details of for example, Basildore Transport. I know we mentioned that last meeting, but it's just things like that where I think the committee needs to be reassured that the wool's not going to be pulled over our eyes, and I plead with our chairman and vice chairman as well, just to keep an eye. You don't have to come to us with that, or is this group do? But just keep an eye on making sure that we're getting the full details, and the people are getting the full details. Because as you can imagine, when it comes to Newark, for example, people don't like the wool being pulled over their eyes, and I know we've been reassured about Newark before and how it has received the investment. Yet people are still worried about it. So it can't feel like it's a an exercise in we can get away with this now. I know public health. You guys want the best for the community. I'm not accusing you of that, but people need to be reassured that that is the case as well. So thank you very much.
Yeah, no, thank you for that. We support that approach as well. So the steps that we are taking, as Victoria mentioned, around the EQIA and the impact assessment, you're quite right. When we look at bucket two is the things that we can do that will have minimal impact, and we're trying to progress them and do as many of those as we possibly can. Where we're looking at what we call service change, there are certain triggers that we will automatically go and have an equality impact assessment, and where we may need engagement or consultation. And those are, is there an impact on the service as a whole, even with relation to opening times or the cohort of patients? Are we changing it for different cohort, or the location of the service? Anything like that will be triggered to Victoria, who's leading that service change review process, in which it will say we need to have a consultation, we need to do that utmost. Victoria and I work very closely together, but very differently in relation to this. My job is delivery, and as Councillor Eddie says, you have to put the human at the end of this. My job is activity, numbers, figures. Are we delivering that red, amber, green? And that's the horrible side of it, and I apologise in advance for that. Victoria's element is that equality impact. What's that going to do with relation to the patient? So I absolutely will be pushing through to try and ensure that we deliver efficiencies in our targets. I'm being open around that. But what Victoria will be doing is pushing back to me and saying that's going to have this impact. We need to take this approach, and that's probably one of the best examples of why we have two people sat here today and not just the one person, because it does demonstrate our commitment to that transparency and process.
Thank you. Councillor Shaw.
Thanks for bringing me in, Chair, in relation to... I've been quite intent on listening to colleagues' contributions, and I thought last night Sky at Night said 5 billion years when sun used up all its hydrogen, and then it was going to expand and engulf the Earth. So anyway, it's not going to affect anybody here. But let's talk about the shining star of the NHS, then, shall we? Because let's use the analogy of Councillor Doddy, the buffet. UK has stark inequalities, and it's still got stark inequalities, and it cannot be right that the life expectancy of people in my division, Mansfield West, dramatically is different from people that sample the smorgasbord of the health service in Rushcliffe. They live longer. So something's got to be done about those stark inequalities. Now, I'm hoping that things in this report will address those problems, because it's been said, and I think it's correct, that prevention will always be better and cheaper than a cure. So therefore, I think what we need to be talking about is how best the Integrated Care Board can work with us, a local authority that has specific interests and has certain influences on public health. If we work together, we can then reduce that problem of the health inequalities that we face in Nottinghamshire. So I think we should look at this report and come back, or get the Integrated Care Board to come back on a regular basis, because it's right. If you're looking at the Group 1 proposals, people in my division aren't particularly bothered whether or not the review of the integrated corporate administration cost of the board are reduced, but there will be concerned if you're talking about rationalising and changing services at their local GP or health clinic. So, you know, we've got to put it into context. So I think what we need to do is get you to come back at some point in the future. Now, I'm not on this committee, I'm only here as a substitute, but I would hope that you'd want them to come back on a regular basis, and particularly when they've looked at things in the group 3 and they've determined what they're going to do, which may have an impact on services, that they come back and tell you all about it, and so you can make your assessments. But one, I think we should be, let's hear how you're going to work with us as a local authority to reduce health inequalities, and two, I think you should come back on a regular basis, whether or not it's 3 monthly, quarterly, or same thing, but you know, regularly to come back and talk to us. And if Councillor Lee wants to talk about services at the City Hospital in relation to amputee services, I could write a book. So if you want to talk about that, but just make those contributions, Chair. Thanks very much.
Yeah, well, I can just say, Paul, that they're due back on the 7th of January. Yeah. So thank you.
We're happy to come back as frequently as you would find that helpful. Absolutely no problem about that. We are very keen to be open and transparent about the decision making that we're doing. If we categorise things into 2 basic camps, transactional, transformational. Transactional, I think what I'm hearing is just get on with it and do it. But actually transformational, you want to hear a lot more and you want to understand that, and therefore what the impact might be. Absolutely understand that completely. That's absolutely the right approach. Happy to come back as frequently as you wanted to go through that. I think the challenge that we've got, haven't we, is that the challenges of today, resolving today's problems, for example, the money, meeting the 100 million target for savings, but also thinking about tomorrow, which is the prevention agenda and what can we do. And what we're trying to do is balance the needs of both those things at the same time, which is not an easy task, as I'm sure you can appreciate. So trying to achieve those efficiencies in here by trying to do things that are just best value. County councillors, you will know this. You've been doing this. You've mentioned it. It's your bread and butter. You've been doing it for years. I think probably we can learn a lot from you in terms of how we do that better. But managing today's problems while also thinking about tomorrow is a challenge that we've all got to try and work together on. I genuinely think that the opportunity to try and place-based working, about creating resilient neighbourhoods, about working in partnership, closer to where patients live, developing the integrated team approach is the future, and that's about a strategic approach, how we all engage in that and work together. Maybe that's a different conversation we have at a separate point in time as well. Obviously working with our health and wellbeing board would be really important as part of that conversation. So there are 2 kind of conversations that I think need to happen and mature. One, how are we dealing with today, but also how do we make sure that we are preparing ourselves for the resilience of tomorrow as well. And happy to engage in whatever way you feel is appropriate for both those.
Thank you. Councillor Jackson?
Yes, thank you, Chair. No, thank you, Victoria, Alex coming, and I know you do come on a regular basis to keep up to date and informed about what's happening in ICU, which we do very much appreciate. Despite what West Scrutiny says, the NHS isn't broken. I'm living proof of that, because a few years ago, well, it wasn't with the excellent skill and quality of caring I received a couple of months ago, I won't be here today speaking to you. So it's not broken. But having said that, I still think it does need a root and branch overhaul. But I actually think it needs to be done by independents. I'm sick and tired of the NHS being used as a political football by governments, kicked about from one place to the other for point scoring. It needs to be independently looked at. It would take more than 5 years, and governments just live in 5-year cycles, which is a great shame. Prevention has been talked about today, which I think is right. Prevention education is so important. You know, helping people look after themselves, diet, smoking, etc., which takes a lot of pressure off the NHS if people, you know, looked after themselves better in the time. And also there's a lot of pressure on GP services. A lot of people have to go to A&E because they can't get to GP. So I did wonder if the 111 number is a success and working well, or the walk-in centres, how many people actually use those, what people do use those as an alternative to going into A&E or using services and things like that. Because I think I'm right in saying, I think there's been a 6 billion nationally increase in the NHS budget over the last few years. And I just wonder how much of that actually filters down to Nottinghamshire or your organisation. And I would also like to ask, when you do come back to treat us again, I don't know when you're down to come back, we could do a little bit more information where you're making the savings. I mean, I actually think there needs to be a real look at the structure of the working structure. So I think, I don't think that's been looked at in a long time. There's layers of management there. I think probably could be looked at and things like that. Not the front line, but I think there's different areas that could be looked at for savings. Because I'm sure you said earlier that your heating and energy is probably your highest, but actually I think probably wages is probably your biggest bill going right through. So I think there's an area to be looked at there as well, but not cutting the frontline services. But as I don't think it's ever been looked at. I mean, councils have been the same. People put in place and it's never been checked or over the years, and probably a lot of people there duplicating jobs, which probably is not necessary. And I think that's an area that could be looked at. So that's just a few questions for you to try. Thank you very much, and I thank you for all the services, because I won't be here without you.
I'd like to come back to that, and that it's really nice that you say some of that. Particularly, I was in a meeting this week when we hear the NHS is broken, and I recognise what you're saying. I think the NHS has a way to go, but with the hundreds and thousands of people who work within it, they don't need to hear that every day. What they need to hear is we have room for improvement and you're doing a great job. And I think that's the message that we are keen to get through to our local community, that we have ways to go, we have room for improvement, but you're doing a fab job and we're behind you to help you get better. I think with regards to some of the things that you were saying about 111 and urgent care treatment centres, it's actually something that we're starting to look at. Last year we got something awarded to us called the Section 251, which means that we could link data legally. And what we can do now is we can track if somebody rings up 111, did they end up going to their GP practice? Did they end up just pitching up to urgent care? And that gives us a story on how productive things are working. So did somebody ring 111 and end up going down to the urgent care treatment centre anyway? We don't know that yet, and that's some of the reviews that we're doing. But giving us access to that data, which we're one of the only few areas that have been given access to that data, allows us to do that deep dive. And that's where we're going to start looking at 111 and treatment centres and how we can use it to the best locally to enhance some of the services that we offer. But yeah, all of those things that you talked about, again, that's part of when we talked about those efficiencies and doing things better. We need to maximise everything that we have, and 111 and urgent care treatment centres and walk-in centres will be part of that review.
Just to add on that, so yes, there has been an increase. I think Alex has been really clear about saying we've had more money, but our costs have increased quite a lot as well. So there have been inflationary pressures around fuel, for example. We all know gas bills, electricity bills have all gone up. We've had industrial action that we've needed to try and support that has created some issues, and we've had pay increases for staff as well. So it's a combination of things that have added together to put more pressure on the cost side of things, not necessarily about the income. In terms of the management layers that you've said, I can appreciate that's very much a perception that people have, and I know that there's lots of concern that we're putting money into back office functions as opposed to frontline services. What I will say is that international evidence suggests that the NHS is actually undermanaged, and that actually there's a very, very recent report you'll have heard about, the Darcy report that's just been published, that clearly indicates that in terms of international comparisons, we don't spend enough money on managers. Actually, we could do better if we had more managers in the system, and I know that's not always a good message to try and sell to the general public. But it is lovely to hear that you had a really good positive experience locally. I'm thrilled to bits that worked out well for you. But just going back to Maria's point, we've got an awful lot of health and care staff working extremely hard in our local communities, doing their absolute best on a daily basis. No questions asked whatsoever about their level of dedication and commitment to improving people's care and overall outcomes. And I think it's really important that in these conversations we don't lose sight of that, and we make sure that our staff do feel supported and recognised for the hard work that they do. So thank you very much for recognising that.
Chairman, with one question. You said about the wage increase, which obviously that staff and junior doctors. Does that come directly out your budget, or is your budget help to increase that extra cost by the government?
There is some help that we receive, or provider organisations do receive. Yes, it does, but it doesn't always necessarily cover the complete costs associated with some of those cost increases. There's a lot of detail in there. I'm being very, very generalistic, but yes, sometimes they're not always as balanced as we would like them to be.
John.
Thank you very much. In my report, I forgot to ask you 3 very important questions, and as far as I'm concerned, that's what I should have done in the first place. It says deferring some investment in services. Won't that reduce the service overall? If you're deferring anything, will that be a problem? And it says whether there is alternative service provision. What is alternative service provision? What can you tell me what that is? An alternative service provision. And in the report, one of my prime objectives is to try and talk about preventative work. I can only see preventative work in one word in the whole of the area. Surely you are investing on some schemes, prevention schemes, but there's nothing about it at all in the report. I just wondered if you could update us on that. Thank you very much.
3 quite succinct points.
Yeah. So I can answer 2, and then I'll let Victoria and the last. So deferred services, or sorry, what was the one you talked about?
Deferring investments and
deferring
alternative services.
An alternative, yes. So ultimately, this is what I was talking about. So sometimes we may have national monies come down non-recurrently, and ultimately, what we do is what we are doing now is we're not investing in, or some of those, we're not investing in some of those services. It's not that we're cutting back in those services, but what we're saying is we have a 1-year non-recurrent money, we're not investing in it, we're going to defer it. And the reason why we're doing that is because we assess what's already there. So an example might be that nationally they say there is a pot of money, could be £50,000 to invest in diabetes services. I'm speaking generally. And what we do is we look at, do we already invest in diabetes services? Have we already got diabetes services invested? Yes. Do we have any gaps? Not really. So let's hold on to that £50,000 and put that in the bottom line pot, because it's non-recurrent, which means we're never going to get it again. We can't recruit permanent staff to that post. So actually it's a better way of how we invest some of that non-recurrent monies. So that's what we mean about defer. So we're not taking money away, we're not reducing activity, but we're not adding non-recurrent money.
So it's still reducing the service overall in the end, from the end product.
No. Yeah, so what we're doing with regards to the alternative services is we're looking at, is there alternative service already out there? So again, and I think that's what I was kind of saying around the diabetes. So if we're being asked to invest in a new service, we'll look at what's already there and say, could we pick that up as part of that specification? Could you pick up this cohort of patients? Is it that it's a different age or a different criteria, and could that service pick that up, rather than invest in another £50,000, bringing in another layer of a service that sometimes becomes confusing? And what we're finding when we're speaking to some of our clinical and professional groups, they're sometimes finding that this non-recurrent monies that are coming in can be quite confusing because it adds layers and adds confusion.
Thank you. I think Roger.
Prevention. It didn't answer the question on prevention.
I think we have, throughout the previous conversation, had absolute assurance about the commitment around prevention. It may not be as prolific in the paper as you would like, but I think we've had a good conversation about our commitment around that agenda.
Thank you, yeah. Councillor Jackson summed up the issues in the meeting a few minutes ago, so I have no intention to go any further with that. We've got some recommendations here, And the recommendations are: 1, that the report, including additional information regarding the decision-making process, be noted, and 2, that a further update regarding the potential impact of decisions be received at an appropriate time. Are we all in acceptance of that? Thank you very much, guys. Thank you. Thank you for your time, and
thank you.
We've just got the work programme too. Sorry? If you want slow.
Before you go, Alex, Newark Hospital's coming up on the agenda. I just don't know if there's something we can organise a visit for the members that didn't do it last time, because I think that will make it really, so people can understand what you're doing at Newark, because it really helped me when I looked at it before. Sorry.
Yeah, for agreement with the chair and colleagues, very happy to organise that.
Sure, get out.
Yeah. Thank you. Thanks, Al. Thank you. Thanks a lot. So moving on to the work programme. Work programme reflects a shorter year with fewer meetings this year due to the pre-election period next spring. Therefore, we're very selective around agenda items for the year. Some items have been requested previously, and prioritisation of any additional items will be based on these criteria. The highest priorities for the health scrutiny this year are: 1, items relating to substantial variations to services. Our partners have a statutory requirement to bring proposed changes to scrutiny, for example, financial sustainability item, which we'll be looking at further in January. 2 items directly relating to partner organisations' ongoing progress on significant improvement journeys, such as the report from NHT we considered today, or the maternity services update we considered at a previous meeting. These will be scheduled at the appropriate time. And thirdly, emergent items that may come up as the year goes on. An element of flexibility is built into the work programme so that the consideration can be given to an emergent item where scrutiny can add value strategically. So if you know of any further items that fit these criteria, you're invited to make representations in the meeting, or email the chair, vice chair, or Catherine for consideration. John.
Chairman, this isn't a criticism to you. It's not a criticism to anybody really. But I've been asking for prosthetics and to go on the agenda for 4 years. And if someone who's an amputee doesn't ask for it to go on, if I'm not an amputee, I'm going to guess it's never going to end up on there. It's a service that is used by many, many people, usually people that have already been through the service with other medical issues, as Councillor Doddy will tell you. Is the services are lacking in Nottinghamshire, they're rubbish. If we don't at least have a look at it and bring it to the agenda at some point, so then the future, whoever's elected can then have it on the agenda, it's never going to be looked at. And it's something I've been asking for, and I think the councillor to my left has also stated that he believes the services to be quite poor. Is no one's ever going to look at this unless we do.
Thank you, Chairman. As mentioned in the previous item, the health and wellbeing provision in Ucknall remains on the work programme, as I can see, but it is yet to be allocated a date. I can't impress on you more how important it is that we, as a collective voice of this whole committee, to get some answers on the situation. Can I ask that you look into it, this issue is allocated a date as soon as possible, because it's now been a long time since we agreed a holding position on this. Thank you.
We can look into it and see what we can do, John.
Yes, just some of you may be aware that I put forward a motion to full council, and it was turned down, and it was about making health scrutiny a more dynamic and responsive unit to the deteriorating, ever-changing provision of healthcare to the population of Nottingham. It suggested that we should have a subgroup of 4 members, because we've been bulked up by extra 2, and that they should actually work to look at the acute changes materially affecting our residences and bring matters back to populate the work programme on the inescapable fact that the provision of healthcare in Nottingham is no longer a provision, it's an illusion of a service, with the one exception of Councillor Jackson. So he may be the only person that's been salvaged from all of this chaos. So I believe that there's a lot on this, but I believe we're not even touching the actual problem. We're not seeing it because we don't know it exists, and therefore it's not been brought to us. So although this motion was turned down this time, we'll tweak it so it comes back again. But we need an active subgroup actively looking around all of the areas and bringing things directly, like Jono's prosthetic limb service, that, you know, unless he pushes for it, where is it coming from? Dynamic and responsive. They're the words I'm going to say to you. That's what we need in the year going forward, and particularly when we see these people coming in and saying they're cutting budgets, and putting them in group 2, group 3, it doesn't matter. But it's an illusion of a service. We need to be more dynamic. We need a subgroup. We need to be bringing the people before us that we can influence, not bringing them before us because the world is going to end, Councillor Wilmot, in 5 million years. Although you can put it forward, but I don't think it'll make the agenda. Okay, that's it. We need more dynamism, and we need a subgroup working to create that.
John, Catherine would like to come on.
Yes.
Thank you, Chair. So you're absolutely right, Councillor Doddy, that we need to be listening better. And I think one of the ways that we can work with partners is by working with our Health Watch partners. So we already have a partnership that does this listening work that you're talking about. That's dynamic. That's, you know, bringing in voices from the community in a really impactful way. And I think that can be done even further. I think we can further our partnership. I've talked with the chairman and the vice chairman about this, and I'll be taking those conversations to Health Watch to see how we can partner even more closely with them. So I think what you're describing is also very positive, but I just wanted you to know that there are conversations in the works to do just that.
Dynamic means different things to different people. Some people getting off a chair and turning on the TV is dynamic. Other people are running marathons. So I accept what you're saying, but I think it'll deserve a bit of scrutiny itself. Thanks.
Chairman, I think we mean responsive.
Yeah. Thank you.
And then we've got recommendations.
Sorry, Chair.
Councillor Bailey, yeah. Sorry.
Well, can I just thank Chairman and the Vice Chairs, both current and previous, for streamlining the work programme a bit. At the start of the term, it was very long. We were never going to get through it, but now it seems to be in a bit more of a reasonable state. And as you mentioned, there's not much else we can really add on it yet. What I would possibly suggest is that for areas such as what Councillor Lee has suggested, if it's not on for this year, put it on there for next year. So if none of us return, or if we all return, at the very least it's a starting point, because if it's not discussed before the election, it definitely needs to be discussed after the election. The only other thing I'd possibly suggest is Bassett Law hospitals in the next items. We've spoken about a visit to Newark. Possibly suggest having a visit to Bassett Law to look at the new A&E ward and the mental health provision. I believe that health scrutiny meeting's in November. If we can do it before, great. Otherwise, afterwards. That'll be my suggestion. Thank you very much.
Thank you. Paul, yeah.
As a substitute member of this committee, I still think I've got a contribution to make in relation to Councillor Doddy's point, because at the end of the day, if we've got things in place, that's fine. But if we take on board his recommendation or his suggestion to set up this other group, it might give us more impetus to look into things into more detail and things that are of interest to people. So therefore, I would hope that the committee would support him in that recommendation. Can it anyway?
we just need to get through these recommendations, guys, girls and guys. So I'm not pushing anything under the table. I'm sure Roger and myself and Catherine will be on this. So recommendations that the work programme scrutiny committee be noted, the authority be delegated to the health scrutiny lead to update the work programme as appropriate in consultation with the chairman, vice chairman and representative of the relevant partner organisations, with any changes reported to the next meeting. So all that remains. Are we okay with that? Those recommendations? I don't know if there's enough of us here to.
I think the recommendation from Councillor Doddy was that we set up this additional subcommittee to look at things of interest. And if he's moved it, I'll second it.
Do you want to come in? Do you want me to come in?
Just bear with us a second, guys.
I'll come in a minute. Okay. Thanks, Chairman. So I love to hear ideas like these from a perspective as a scrutiny lead. I love to hear members saying, "Let's do more." Okay, but from a governance perspective, we need to think about how this would fit within the framework that we're working in within the council. So scrutiny can take so many different shapes and formats. So if there's research that you want to do, if there's a project you want to do, please have a conversation with me so that we can support your energy in the direction of scrutiny that's going to be as productive and as value adding as possible. So that's what I'd say to that. But we have to make sure that in terms of governance, that it also aligns with what we can do, in terms of our constitution, in terms of what we're empowered to do, legislatively as well. So we just need to make sure that everything's all aligned before I promise you that yes, we will, or before I recommend that we add any kind of recommendation yet. But I suggest that we look into it. And does that sound like what you would agree with?
I entirely agree with that, Catherine. It is just about looking at, as you say, items can be suggested by the committee, added to the work programme. We go away, we look at those reviews, get the relevant legal advice, and also making sure that it is within the constitution. So,
just as long as it's before the world ends, as Councillor Winmust has warned us. So that's the only time limit I'll put on you.
Thanks, officers. Thanks for everybody attending and contributing today. Thank you very much.